Indian Society for the Study of Pain has been promoting education, research, and collaboration in the field of pain medicine. Today, we recognize an inspiration for all the generation of physicians. To commence the event, I'd like to invite upon stage Dr. Debanjali Roy, who is an anesthesiologist and a consultant pain physician at Apollo Multispeciality Hospital, Kolkata. Currently, she is the secretary of the West Bengal Society for the Study of Pain. Dr. Ray is well known for her enthusiasm, dedication, and various courageous activities like World Tour on the Wheels for the awareness on pain management. Ma'am, please come on the stage. I would humbly invite on stage Dr. Subhrata Roy, the Senior Consultant, Anesthesia and Pain Management at KPC Medical College. He is the founder figure and faculty of ESI Institute of Pain Management. Dr. Ray has been engaged in many state and national level workshops, teaching us since last 30 years, and currently he is the president of the West Bengal Society for the Study of Pain. Please grace the stage, sir.
Today's program, I have to start with my heavy heart. We at the WBSSP extend our deepest condolences for the passing of our mentor, Dr. Subhrata Goswami. It is undeniable that his guidance, wisdom, and sacrifice have had a profound impact on all of the pain physicians of West Bengal as well as all over the India. Everyone who had the privilege of knowing him as a pain physician will remember his dedication and contribution for the subject. His honest contribution as a pain physician in India is indisputable. Losing such a respected figure is a tremendous loss, not only for WBSSP, but for the academic community as a whole. His legacy as a mentor will continue to live on through his teachings and inspiration. May his soul find solace in the cherished memories, and may his spirit continue to guide us on our journey. So for the demise of our sir, now we will stand and maintain a silence of 1 minute. Please keep your mobile phone switched off. Thank you very much. Now I would request our President, Dr. Subhrata Rai, to say a few words about Dr. Goswami.
Good afternoon, all respected members. As our secretary has said, we all are here with a heavy heart. Initially, we had a plan for a small presentation over the pain scenario in India and the role of ISSP, but we have changed that. We will just mention a few words about Dr. Goswami, because from our society, we will organize a separate condolence for him, and we will announce it in due time. Dr. Goswami was 2 years juniors to me. When we started working together, as a group. Dr. Gautam Das is here, Dr. Ramapati Sannal, Dr. Krishna Poddar, Michelle Poshami, and there is a group of young physicians who tried to follow the path shown by our senior teachers. They are also here, Professor Ushrukuna Roy, Professor Sagormoy Bosu, and many of others who are not here. But within a short period, he has shown his capability of leadership. He has grown up from a student of pain to a successful, respected teacher of pain medicine, and he has built up an institute fighting against all hurdles of government machinery. So I want to show though he is junior to me, I think he has reached a stature higher senior to my position, and I express my respect to him on behalf of the society. Thank you all.
Thank you so much. We have our chief guest for the evening with us, Dr. Abhijit, Major General Dr. Abhijit Chakraborty, Group Medical Director from Medica Group of Hospitals. Sir, please come on stage, sir. We would like you to pay tribute to Dr. late Shubhata Goswami.
I would like to call Dr. Sagormoy Bosu sir to first garland sir.
I'd like to invite upon stage Dr. Oshrukana Mitro. Dr. Shubhrata Ray, sir, please come on the stage, sir.
I would like to request Dr. Shakil Akhtar to come and Galvan.
I'm delighted to welcome on stage our chief guest, Major General Dr. Abhijit Chakraborty. Please, sir, come on the stage and share a few words of wisdom.
Respected guests who have come to attend this evening occasion with us, good evening to all of you. A warm welcome to all of you to this new oncology block that has been commissioned a few months back. The commissioning is not yet complete, but at least almost complete. Dr. Amiya Mishra came and asked me whether I would like to come as a chief guest. Well, I don't want to really come as a chief guest because I don't belong to your specialty. But I surely would like to come and attend and listen and get myself educated on this particular subject. What surprises me is when they told me about pain medicine, and that pain is not really new to any one of us. We knew pain since time immemorial. If you look at the ancient scriptures, they have all spoken of pain. Our Bhagavad Gita has spoken of pain and suffering and immortality of soul. So it's not a new phenomenon. But if I remember my childhood, I remember my early days of medical education, we have been told that, well, tolerating pain is manliness. Post-operative pain will be there, and the patient has to bear that pain. Nothing much can be done about it, and that shouldn't be expected. But today I am being told by Dr. Argo that that's not so anymore. Pain now today has become the sixth vital parameter. And why should a patient suffer from pain, particularly in a multi-speciality hospital like ours? And what surprises me more is that if the society has been established for 40 years now, even in a hospital like Medica Super Speciality Hospital, other than a few anesthesiologists who speak of pain, we don't speak of acute pain service. I mean, the first thought that came to my mind is that why in our hospital we do not have an acute pain service? So possibly that's a very contemporary subject that will be discussed today. And I'm sure after this evening, all of us will go back better educated on the subject of pain. Welcome to you all again. Thank you.
I'd like to invite on stage our HOD of the Department of Anesthesia and Perioperative Care in Medica Super Speciality Hospital, Dr. Amyo Kumar Mishra, and Dr. Orgo Mukherjee to please come on the stage and felicitate Dr. Debanjali Roy, Dr. Obhijit Chakraborty, and Dr. Shubhrata Roy. Debanjali ma'am. Ma'am, please come on. Dr. Obhijit Chakraborty. Dr. Shubhrata Roy. So, moving ahead with the CME, let us start our academic session now. The chairperson for this session will be Dr. Krishna Poddar, Director, Kolkata Pain Clinic. She has done FIPM, FIAPM, and various fellowships in pain management, has been trained in USA, Europe, and Australia. She is the faculty and in charge of the fellowship program in Southeastern Railway Hospital. I'd request Dr. Abhiroop Nayak, MD Anesthesiology, FPM, ex-senior resident at Tata Memorial Hospital, Mumbai, Associate Consultant Anesthesiology, Pain Management and Perioperative Care at Medica Hospital, Kolkata, to throw light on this session. So, I'd request the patients who have volunteered. I'd request the patients to for the session on live demonstration of history taking and examination of the shoulder pain session to please come on the stage.
Good evening all. So I will be taking a few case scenarios and hello, am I? Good Good evening. Good evening all seniors and colleagues. So I have been asked to present a few case scenarios. So we have here 3 patients here who had who had this history of pain in the shoulder at some point of time, have undergone some kind of treatment. But we will be trying to focus on the pain that they had when, try to focus on the pain that they had during that time before their treatment. So I'd like to introduce them first, ask them to introduce themselves. আপনারা একটু আপনাদের পরিচয় দিন। আপনি? আচ্ছা, আপনি? আচ্ছা। So they are more comfortable with Bengali, so I'll just have an interaction with them in Bengali regarding their history of pain. আপনি একটু বলুন আপনার ব্যথাটা কতদিন আগে হয়, কবে কিভাবে হয়?
আমি হ্যালো, আমি গত ফেব্রুয়ারি মাসে 22-এ একটা অনুষ্ঠানে গেছিলাম, সেখান থেকে পড়ে গেছিলাম। সিঁড়ি থেকে পড়ে গিয়ে আমার এই হাতে প্রচণ্ড পেন হয় পড়ে
তো
গিয়ে
আপনার বাঁ হাতে চোট লাগে,
হ্যাঁ,
আপনার
বাঁ হাতে।
হাতটা পড়ে
বাঁ
গেছে।
হাতে পড়ে গিয়ে চোট লাগে।
তো তখন ব্যথাটা কিরকম
তখন
ছিল?
ব্যথাটা প্রচণ্ড ব্যথা ছিল, প্রথমটা বুঝতে পারিনি, তারপর প্রচণ্ড এমআরআই করিয়েছি।
আচ্ছা, সেখানে আমরা পরে যাচ্ছি। বলছি তাতে ব্যথাটা আপনার ওখানে কিরকম দপদপ করতো না
না,
ঝিনঝিন
পড়ে যাওয়ার
করতো?
পর প্রথমটা বুঝতে পারিনি, তারপরের দিন থেকে দপদপ দপদপ করতে।
আচ্ছা, ব্যথাটা কি ছড়াতো কাঁধ থেকে কোনো দিকে?
না, ছড়িয়েছিল, অনেকটাই ছড়িয়েছিল, পিঠগুলো ইয়ে হয়ে গেছে।
আচ্ছা, ব্যথার জন্য রাতের ঘুমের কোনো অসুবিধা হতো?
খুবই অসুবিধা হচ্ছে।
কি করলে বাড়তো?
না, এই সাইড শুতে পারতাম না।
আচ্ছা, আর কাজকর্ম করতে হাতের কোনো অসুবিধা হতো?
হাতটা তুলতেই পারতাম না।
আচ্ছা, আর কি করলে কমতো?
দুঃখ করতো। কিন্তু তারপরে আমি নারায়ণতে ডাক্তার, অর্থোপেডিক ডাক্তার একটা ঘোষ, বৈদিক ঘোষ, ওনাকে দেখিয়েছিলাম। উনি দেখে তখন ঠিক একটা থেরাপি একটা দিয়েছিল, ওয়াক্স থেরাপি।
তাতে কি কিছু লাভ হয়েছিল?
তাতে আমার কোনো লাভ হয়নি, লাভ হয়নি।
তারপর
তারপর
কি করলেন?
ওনাকে বলেছিলাম, উনি তখন বললেন ঠিক আছে, এটা তো অনেক সময় সাপেক্ষ, এটা হবে না, তা আপনি বরং আমি একটা দিচ্ছি। তা আমার জামাই মানে ছিল ওই হসপিটালের ডাক্তার এবং মেয়েও তাই, তো ওরা তখন নিয়ে গেল আমাকে ডাক্তার অর্ঘ মুখার্জির কাছে। উনি দেখে টেকে আমাকে দেখলেন।
তারপর কি ট্রিটমেন্ট পেয়েছেন?
হ্যাঁ, তারপর উনি আমাকে ট্রিটমেন্টটা করলেন, যে আমাকে ভর্তি করালেন, মানে ডে কেয়ারে ভর্তি করিয়ে উনি বললেন যে একটা ওই আপনার ব্লাড টেনে সেটা দিয়েই একটা।
আচ্ছা, পিআরপি থেরাপি বলে, পিআরপি করা। আর তার সঙ্গে ব্যথার জন্য আর কিছু করা হয়েছে
না,
ব্যথা কমানোর জন্য?
কিছু না, একটা ওষুধ দিয়েছিলেন, কিন্তু কোনো আমার ওষুধ খেতেই হয়নি। পরের দিনই ব্যথাটা কমলে, আপনার পরের দিনই কমে যাবে ব্যথাটা, কোনো রকম চিন্তা নেই, আস্তে আস্তে। তা আমি দেখলাম সত্যি আস্তে আস্তে কমে গেল, যেটা কমতে গিয়ে আমি তখন
তার সঙ্গে একটা কোনো ইনজেকশনও দেওয়া হয়েছিল হয়তো পিআরপি?
তখন হয়তো দেওয়া হয়েছিল। তো কিন্তু আমি পরবর্তীকালে দেখলাম যে না, আমি হাত ফাত পুরো নাড়তে পারছি।
এখন বেটার আছেন তাই তো?
এখন তো অনেক বেটার।
ঠিক আছে,
এখন অনেক বেটার।
একটু ওনারটাও শুনে নিন। আপনি বলুন আপনার কি সমস্যা ছিল, মানে আগে ওনার
আমি রবীন্দ্রনাথ অধিকারী, আমার বয়স 65। আমার বছর 15 আগে এই হাতের ভিতরে এটা হয়েছিল, হ্যাঁ, সেখান থেকে কিছু যন্ত্রণা ফার্স্ট হয়েছিল, হাতটা ভীষণ ঝিনঝিন করতো, ঘুমোতে অসুবিধা হতো। তারপর
হাতে কোনো কিছু ছিল, মানে টিউমার মতো কিছু হয়েছিল হাতে? কিছু ব্যথা? যেটা
ব্যথা ছিল না, শুধু একটু ঝিনঝিন করতো।
আচ্ছা।
ওই থেকে তারপর হোমিওপ্যাথি ওষুধ খাওয়ার পর ঠিকঠাক ছিল, বেশ কিছুদিন ভালোই ছিলাম। তারপর হঠাৎ দেখি এই মাঝে একটা বড়
ফোলা মতো?
হ্যাঁ, ফোলা হচ্ছে ওখানে।
তখন ব্যথাটা কিরকম ছিল? তখন ব্যথাটা ছড়াতো?
তখন ব্যথা কিছু ছিল না, সেরকম অনুভব করতাম না। হাতে কোনো মাল জিনিসপত্র তোলা ফোলা কোনো কিছু অসুবিধা হতো না।
ছিল না। তারপর কি ট্রিটমেন্ট হয় তার?
তারপর হঠাৎ ওই ফোলাটা বাড়তে শুরু করলো। বাড়ার জন্য তখন ওই সার্জন ডাক্তারের কাছে গেলাম। উনি তখন বললেন যে আপনি চিত্তরঞ্জন হসপিটালে চলে যান, ওখানে গিয়ে দেখান, তাহলে বুঝতে পারবেন।
সার্জারি করাতে হয়েছিল?
হ্যাঁ।
সার্জারির পর কি তাহলে ব্যথা ঠিক হয়ে গেল?
না, ব্যথা তো ঠিক হয়নি, এখন তো ব্যথা আছে। ওনার চিত্তরঞ্জনে দেখানোর পর ওখানে 3টে কেমো দিয়েছিলেন। কেমো দেওয়ার পর ওখানে হাতটা, সবাই বলছিল যে হাতটা আপনার চলে যাবে, কেটে দিতে হবে। হ্যাঁ, আমি টাটা মেডিকেলেও গিয়েছিলাম, ওখানেও দেখিয়েছি। ওনারাও বলেছিলেন যে আপনার হাতটা থাকবে না, হাতটা চলে যাবে।
ফাইনালি অপারেশন হয়েছে?
অপারেশন করতে।
অপারেশন হওয়ার পর এখন ব্যথা মুক্ত আপনি?
তারপর ওখান থেকে আমাকে নারায়ণীতে দিল ডক্টর নন্দী, ওনার কাছে আমি দেখিয়েছিলাম। উনি অপারেশন করেছিলেন নারায়ণীতে। অপারেশন করার পরে মোটামুটি ভালো, কিন্তু ওখান থেকে অনেকগুলো থেরাপি করতে বলেছিলেন, সেই সব থেরাপিগুলো আমি করিনি। যার জন্য এখনও আমার ওই
এখন
হাতের
ব্যথাটা কি
ব্যথা বলতে ওই
কি মনে হয় হাত তো নেই, তাহলে
হাত
ব্যথা
তো
হয়?
নেই কিন্তু হাত আছে, মনে হচ্ছে হাত
আচ্ছা,
আছে,
আপনার মনে হয় হাত আছে।
ওইটাই বয়ে নিয়ে চলতে হচ্ছে।
আচ্ছা।
ওই ব্যথা
তার
এখন
জন্য কি ট্রিটমেন্ট নিয়েছেন কিছু?
ট্রিটমেন্ট ওই মেডিসিন দিয়েছিলেন, আর কোনো থেরাপিগুলো করা হয়নি।
কি থেরাপি বলেছেন আপনি?
মিরার থেরাপি বলেছিলেন, মিরার থেরাপিটা করা হয়নি,
আচ্ছা,
যার জন্য এখনো পর্যন্ত আমাকে ওইটাই নিয়ে চলতে হচ্ছে।
ঠিক আছে, ধন্যবাদ। আপনি বলুন আপনার কি ধরনের ব্যথা ছিল, কবে হয়েছে?
আমার হ্যালো, আমার বছরখানেক হবে এই বাঁদিকে ক্যাপসুলটার নিচে একটা মাথার এখান থেকে একটা পেন বয়ে যায়। বয়ে যেতে যেতে আমি প্রচণ্ড মাস চারেক হবে আমি মেডিকাতে আমাদের অফিস ফেসিলিটি আছে, আমাদের টাকা পয়সা লাগে না, কার্ড ফেসিলিটিতে দেখাতে পারি। তো আমি ডক্টর একদিন পিঠে ব্যথা নিয়ে, খুব প্রচণ্ড পিঠে ব্যথা নিয়ে আমি ডক্টর অনিশ ঘোষের আন্ডারে ভর্তি হই। তখন উনি বিভিন্ন রকম টেস্ট তো কিছু বাদ দেননি, সবই হয়েছে, সিটি স্ক্যান থেকে ব্রেন সব কিছু হয়েছে। হওয়ার পরে তারপর উনি আমাদের যথারীতি পেন বিশেষ কিছু কমেনি। আমি দীর্ঘদিন
ব্যথাটা কি ধরনের ছিল বলুন? মানে
ব্যথাটা তখন উপস্থিত কমে গেছিল, তারপরে আমাকে ছেড়ে দেন, আমি বাড়ি চলে যাই। তা মোটামুটি বাড়িতে সুস্থই আছি। তা হঠাৎ আমার আর কি পেনটা আবার বাড়ার পরে তখন আমি ছেলের সাথে পরামর্শ করে দেখি, তখন বললো যে ঠিক আছে, তুমি ছেলে বললো যখন বড় হয়ে গেছে, তো ছেলে বললো তাহলে ঠিক আছে, আমি মেডিকাতে পেন ম্যানেজমেন্ট ডক্টর অর্ঘ মুখার্জির সাথে কথাবার্তা বলি। তা উনি কথাবার্তা বলে ও সার্চ করে পেয়ে তখন আমি ডাক্তারবাবুর কাছে আসি। ডাক্তারবাবুর কাছে আসার পরে
কিছু করলে বাড়তো বা কিছু, ব্যথাটা কি ধরনের ছিল?
ব্যথাটা
করতো, ঝিনঝিন করতো,
ব্যথাটা
কোন জায়গাটায় ছিল?
না সেরকম কিছু না, এখান থেকে বয়ে যেত আর কি ব্যথাটা।
ছড়াতো কোনো দিকে?
হ্যাঁ, হাতের এদিকেও আসতো, আবার পায়ের এখান দিয়ে চলে যেত, ঝিনঝিন করতো আর কি। আমরা বাঙালিটা যা বুঝি তাতে ঝিনঝিন।
কিছু ট্রিটমেন্ট হয়েছে?
ট্রিটমেন্ট হয়েছে, ডক্টর অর্ঘ মুখার্জি প্রথমে কিছু ওষুধ দিয়েছিলেন, কিছু ব্যায়াম দেখিয়ে দিয়েছিলেন। তারপরে আমি সেগুলো বাড়িতে করেছি, করার পরে আমি দেখছি আগের থেকে একটু ভালো, তাও দেখছি যেন কিছু সেরকম প্রগ্রেস হয়নি। তারপর ওনার কাছে আবার আসি, উনি তখন ড্রাই নিডল থেরাপি করলেন। একদিনকে বললেন শুয়ে পড়ো, তারপরে আমি খালি গায়ে শুয়ে পড়লাম। আগে কথাবার্তা বলা ছিল, তারপর শুয়ে পড়লাম।
এখন সেটা করার পর কিছুটা কমেছে?
সেই জায়গাটায় কমেছে, কিন্তু তার নিচের থেকে এখন আবার আসার সময় হয়ে গেছে ওনার কাছে, তার নিচের থেকে পেনটা আবার দেখছি শুরু হয়ে গেছে। পেনটা শুরু হয়েছে, এইসব দেখে আরো বেড়ে যাচ্ছে।
ঠিক আছে, ধন্যবাদ আপনাদের সকলকে, অসংখ্য ধন্যবাদ এখানে আসার এবং আমাদের সঙ্গে এই শেয়ার করে নেওয়ার জন্যে। আপনারা থাকুন, আপনারা বসুন, পুরো ডিসকাশনগুলো, বিষয়গুলো শুনুন, কারণ এই পুরো প্রোগ্রামটা কাঁধের ব্যথা এবং শোল্ডার পেন নিয়েই হয়। তো আপনারা আরেকটু থাকলে আরও অনেকটা কিছু জানতে পারেন। প্লিজ বসুন। হ্যাঁ, ঠিক আছে।
So now we'll try to call upon a volunteer on which we'll try to show the examination that we need to do for the shoulder pain assessment. ওরকম তুই স্যারেরটা the activation process, the clockwise process, and also the scapula. And here also we compare with the normal side. And also if there is any tender points that will cause any malfunction in clinic. Then after palpation, we examine the range of motion for the shoulder side. So for range of motion, we can see a few movements like the isolated abduction, the forward flexion, then the internal and external rotation of the arm at 0 degree, then with the arm abducted, the internal and external rotation, and also the horizontal adduction. For range of motion can be, if it is restricted, that can be diagnosed with the Aptis scratches. For Aptis scratches, you have to ask the patient to touch the opposite scapula with his affected hand. This shows the external rotation and abduction, and other way, the internal rotation and the adduction. If that is further affected, that can signify the pathology. Then after range of motion, we come for muscle strength. Muscle strength basically we assess the rotator cuff muscle strength. Here we can look for the empty cat test. For empty cat test, we'll ask the patient, I'll stand for patient, I'll ask the patient to abduct up to 90 degrees both the hands. Then we have to ask the patient to stand up to 30 degrees and then internally rotate both the hands. Then the examiner will put the resistance, downward resistance, the patient will resist with downward force. If there is any weakness, you have to mainly focus on the weakness of the muscle. The affected side will have less strength. This mainly addresses if there is supraspinatus pathology. Then after the second test, we will ask go for the belly pressure. So we will ask the patient to press on the stomach. Here, if there is weakness, the patient will not be able to maintain the full internal rotation. That is mainly calculation of the muscle and the shoulder elbow will drop back. For this position, there is extension of the shoulder and flexion at the wrist. After this, we have to also test for the other two muscles of the rotator cuff, the flexor spinatus and the iliopsoas. Here, the patient is asked to put the hand by the side, flex the elbow, and the patient will try to do the external rotation against the resistance. If there is weakness, then some muscles may be after muscle strength, we'll go for the special tests that we do. So first will be the impingement test. For the impingement test, we do the neck test, that is stand from behind. The patient will ask to forward elevate his arm and I will try to elevate the arm. I will put the hand on the scapula to prevent any protraction. If there is impingement, the patient will complain of pain. After doing the test, we have the test of how can he test. Here also, the patient will abduct, forward. Will be internal rotation, passive internal rotation. If there is any impingement, then the patient will complain of pain at the affected shoulder. Then we go for the rotator cuff test. This will be the raw palm test. The examiner will be on the seeing from the behind. The patient will be asked to abduct both the arms up to the side 90 degree, and then will ask the patient to gradually lower the arms up to the side. If there is any pathology on the affected side, the shoulder will either, the patient will lean towards the affected side, or there will be sudden drop of the arm. Then the external rotation lag sign. For this the patient will abduct the patient will abduct up to 20 degree, then there will be elbow flexion, and the patient will be asked to externally rotate and I will keep my hand on the wrist and on the elbow, and I will ask the patient to hold at this position. Then I will release my wrist. If the patient is not able to hold at this position, then the lag sign is positive. These two tests signify with some supraspinatus or infraspinatus pathology. Then for the shoulder instability, actually for this we have to make the patient supine. So we do the apprehension test, the relocation test, and also the anterior release test. Due to constraints of our position, we will not be able to show that here. We have to do it in a supine position. Then we will also diagnose for the acromioclavicular joint pathology, the O'Brien's test. For the O'Brien's test, the patient is asked to do forward flexion and the 10 to 15 degrees of adduction, and the patient is asked to do the internal rotation, and I will give a downward pressure, and then the patient is asked to make supination. The patient will complain of pain while doing this internal rotation against the downward resistance. This test has more specificity, and if this test is negative, then we may also go for the palpation of the acromioclavicular joint for the tenderness, that has more sensitivity. Then finally for the bicipital tendinitis, we have to do the speed test. For the speed test, the patient is asked to forward elevate up to 90 degree, the elbow is extended and the forearm is supinated. I will apply a downward pressure. The patient will try to resist this as if he is trying to flex the elbow. In case there is a pathology of the biceps, then this bicipital group will have the pain. And Yergason's test also, the patient puts the arm by the side, the elbows are flexed, then we will try to supinate it. I will try to resist it. If there is pain, then it is significant of the bicipital pathology. Also another other few points are the cervical spine also needs to be examined. We can do the Spalding's maneuver, where while examiner will stand from behind and will passively do the lateral flexion and downward compression. If there is any pathology of the cervical spine, any facet arthropathy or any radiculopathy, the patient will complain of pain of the same side. Again, the patient can do the shoulder abduction, where the patient will abduct the shoulder and put the arm behind his head. If he is saying that the pain is relieved, then it shows that the compression is released by this thing. Then also this neck distraction test. Here the side examiner will be from behind, one hand on the chin and the other hand on the occiput. I will try to put an axial traction for around 30 to 60 seconds. With this, the neuroforaminal compressions will be released and patient will be having some pain relief. However, patient might complain of pain on this if there is any inflammatory pathology involved. Okay. So these are all the examinations that have been done. Now important thing is we have to rule out some red flag signs. Red flag signs means the patients need to be intervened as soon as possible to release from his pain. So like if there is tumor or any acute rotator cuff tear or any unreduced dislocation, or also in any infection or unexplained significant sensory or motor deficit or any pulmonary or vascular compromise. Then for differential diagnosis, out of all that we examine, we might come to a few differential diagnoses, like if there is rotator cuff tear or tendinopathies like tendinitis or tendinosis, any impingement syndrome or any bursitis or any myofascial pain syndrome, or also any cervical spine disease or any complex regional pain syndrome. So the causes may be a few common causes and a few uncommon causes. The common causes and the uncommon causes are enlisted here. This is arthritis of the pain of the shoulder and acromioclavicular joint pain or subdeltoid bursitis, bicipital tendinitis, supraspinatus syndrome, rotator cuff tear, deltoid syndrome, teres major syndrome, subscapulocostal syndrome, and uncommon causes which may be a bit rare are supraspinatus tendinitis, infraspinatus tendinitis, subacromial impingement syndrome, os acromial pain syndrome, pectoralis major tear syndrome, and also suprascapular nerve entrapment and quadrilateral space syndrome. Our further speakers, next speakers will enlighten upon this. Thank you.
I'd like to invite upon stage our senior consultant from the Department of Anesthesiology, Dr. Mithilesh Tiwari, to please come on the stage and felicitate Dr. Krishna Poddar. Session, I'd like to welcome Dr. Deeposhri Bhattacharya onto the stage. She is a member of the National Academy of Medical and Pain from Arjikar Medical College, Kolkata. Dr. Bhattacharya has organized many conferences in CME. She is the ex-vice president of ISSP West Bengal. She has published many articles in the journals of national and international levels. Today, she will be moderating this session on discussion of different causes of the shoulder pain. To speak on the topic, may I invite on stage Dr. Manish De, MD and Senior Ex-Resident, AIMS, New Delhi. He is Assistant Professor in Anesthesiology and Pain in Shantiniketan Medical College, Associate Consultant in Anesthesiology, Pain Medicine and Palliative Care at Narayana Multispeciality Hospital, Howrah. He has various publications under his name and so please come on the stage to honor the stage.
Good evening, respected colleagues and revered faculty members. My name is Dr. Manish De. Today my topic is on common and uncommon causes of shoulder pain. So after a very exemplary demonstration of the different causes of shoulder, different aspects of shoulder examination and history taking from different patients, coming to the actual theoretical perspective here. So shoulder pain is actually the third most common musculoskeletal condition of the after the low back pain and neck pain. Incidence being 0.9 to 2.5%, and between 30 to 70 years is around 22.9%. The point and lifetime prevalence means 7 to 26% and 7 to 70% respectively. The risk factors being smoking, diabetes, trauma, age and excessive overhead lifting, and common causes being adhesive capsulitis, subacromial pain syndrome, glenohumeral and AC joint arthritis and rotator cuff injury. So the sources will be the bones, the joints, the glenohumeral and acromioclavicular, the capsule, the muscles and the bursa. So this is a brief relevant anatomy of the structures mentioned, and the causes has already been highlighted by Dr. Aviru, so I will go into them one by one. So first I have described the adhesive capsulitis, the incidence being 3 to 5%. It is commonly found in 40 to 60 years of age in females, and it is due to the capsule. The source becomes the thick, inflamed and stiff capsule of the glenohumeral joint. And its risk factors being the same: diabetes, hypothyroidism, and it starts with night pain. And first movement getting affected is the external rotation, and reduction in both active and passive range of motion is the main sign of adhesive capsulitis. So it has three phases: freezing and inflammatory phase, then a fibrotic phase, and then a recovery phase. And coming to the second cause, because there are so many causes, I have to go through them a bit fast. Sorry for that. Incidence will be 5 to 17%. It's a cartilage problem. So it's a progressive cartilage destruction, as we see in knee osteoarthritis also. The risk factors being age, obesity, excessive overhead activities, lifestyle, sedentary lifestyle, dislocation. The pain will be on the posterior and the superior aspect of the shoulder, and there is a reduced active range of motion, but an intact passive range of motion, which differentiates from the adhesive capsulitis. Younger age group patients have rheumatoid arthritis and osteonecrosis as a cause of this particular arthritis. And acromioclavicular joint arthritis is also in a cartilage problem. The main differentiating factor is the scarf test or cross-body adduction test. When the patient or anyone has to put the arm like this and putting a scarf on, then the patient will have pain during the motion, during the movement. So again, it's a reduced active range of motion, but the intact passive range of motion like a glenohumeral joint arthritis. So coming to the rotator cuff tendinopathy, so rotator cuff consists of the supraspinatus, infraspinatus, teres minor, and subscapularis. And in tendinopathy is a spectrum. It starts with an injury, then there is an inflammation or tendinitis, then it becomes a tendinopathy is loss of function, and it might go into tear. So there is lateral, commonly presentation will be lateral shoulder pain with overhead activities, and associated maybe there will weakness and atrophy. And there is again painful active range of motion, and it associated with a subacromial impingement and also in a bursitis also. So it's a spectrum of disease, and we have to diagnose the specific parts separately. And the special test for the rotator cuff tendinopathy, we have to test the muscles. That has already been shown, the empty can for the supraspinatus, the belly press for infraspinatus, the swinging door for the the belly press for subscapularis, the swinging door and for the infraspinatus and teres minor. So the subacromial subdeltoid bursitis. So the name itself suggests that it is a below the acromion and deltoid and above the supraspinatus muscle. So there is an inflammation. So it's inflammation of the bursa. It may be due to trauma, the repeated strain, some rotator cuff injury due to any cause. Then localized pain will be in the subdeltoid area with referred pain to the deltoid tuberosity, especially particularly during abduction. There will be point tenderness over the acromion, and the pain will be provoked by the passive elevation and the medial rotation, as well as the resisted abduction and lateral rotation. It may coexist with the tear. Coming to the bicipital tendonitis, so bicipital muscle, there's a short head and a long head. The short head from the coracoid process of scapula and the long head from the supraglenoid tubercle. So if the long head is inflamed, so there is a tenosynovitis of the long head of biceps tendon, usually the secondary to any shoulder pathology. It may be rotator cuff, it may be impingement syndrome, it may be the superior labrum anterior posterior lesion, knee arthritis also. The pain will be in the bicipital groove and radiating down the anterior arm. It's the anterior shoulder pain. Point tenderness over the bicipital groove over the anterior shoulder. And if this rupture, there is a swelling, it's called a Popeye sign, and it is also being tested, being already shown as Yergassen and a speed test. So coming to supraspinal syndrome, it's a constellation of symptoms. It starts with an injury and a tendinitis and a tendinopathy, and then a tear, and it will have some subacromial impingement associated with it. So I'm coming to it later on in detail. So coming to the rotator cuff tear. So rotator cuff has 4 muscles already been mentioned. Tear is another part of the spectrum. So again, the muscles will have that particular sequence of events. So in younger age group, it may be acute tears due to sports activity or overhead activities, and in older age group, it will be degeneration, and also the reduced healing, not improper healing of the particular tendinitis. It might lead to tear in older populations. So smoking, family history, any history of trauma age more than 60 years will have more risk of rotator cuff tear, and pain will be after trauma with radiation to the deltoid, and tenderness will be near the region of the insertion of the muscles near the greater and the lesser tuberosity of the humerus. So again, the test will be done to see the rotator cuff muscle function, and also in case of tear, the drop arm test will lead to a diagnosis of a tear, and that will suggest that muscle function is lost. So it may be partial and complete, and according to that, interventions are planned. So coming to deltoid syndrome, so deltoid muscle starts from the scapula, the clavicle, and the acromion goes into the humerus. So deltoid tubercle of humerus, its function is the abduction above 90 degrees of flexion, 90 degrees of abduction, sorry. So there will be pain in the anterolateral and the posterior, anterior, posterior, and the lateral. So deltoid has 3 fibers. So anterior, middle, and posterior, according to the pain will be there. But the main suggesting point is that there will be referred pain which will not go below the elbow. it will stay above the elbow, and according to the muscle fiber involved, it will refer to anterior lateral or the posterior aspect. And the risk factor being trauma, swimming, weightlifting, overhead throwing, and the functional inability to raise the arm above the shoulders. So yeah, teres major, coming to teres major is the posterior muscle. It starts from the inferior angle of scapula, goes to the bicipital groove of the humerus, the function being extension, adduction, and internal rotation. So those functions will be hampered because of the teres major syndrome. It's a part of the myofascial pain syndrome, the trigger points being inferior angle of scapula, the posterior axillary fold, and near the junction of the insertion. The referred pain will be in the posterior deltoid, the triceps, the posterior aspect, and the posterior aspect of the glenohumeral joint, and the posterior aspect of the forearm. And the pain will be elicited with the opposite motions, that the flexion, abduction, and the external rotation. Coming to the scapulocostal syndrome. So scapulocostal syndrome is a musculoskeletal condition in the neck and the shoulder region. So it happens because of the dull aching pain in the medial border of scapula, and it can be tested when the patient is told to do this, like putting the arm over the shoulder, and then we press on the medial border of the scapula to see if there is a trigger points there. So if there are trigger points with this posture, it might suggest that it is a scapulocostal syndrome rather than any shoulder joint pathology. So this is another point to differentiate from cervical radiculopathy, rotator cuff tendinopathy, adhesive capsulitis, and rotator cuff disease. The pain may radiate to the above regions mentioned in the neck, in the arm, and also near the chest also. And this is the actual group of muscles from superficial to deep, from where the scapulocostal syndrome can arise. It can arise from trapezius, levator scapulae, or the subscapularis or serratus anterior also with this bursa. Coming to supraspinatus tendinitis, it arises from supraspinous fossa to the greater tuberosity, and the function being the initial 90 degrees of abduction. As we all know, the risk factors being trauma, the age, and the pathology again, it's a near classification of the pathology. It starts with an edema and hemorrhage, then goes to a fibrosis and a tendinitis, and eventually to a rupture. So this is the part of the spectrum of tendinitis. The symptoms being anterolateral shoulder pain, weakness may be there with reduced active motion, again full passive range of motion, and MT can test will help in diagnosing the tendinitis. It will be painful. MT can test will be painful. Patient will be able to do, but it will be painful. And the infraspinal tendinitis is another, infraspinatus muscle comes from the infraspinatus fossa, goes to the medial facet of the greater tuberosity, and the humerus. The external rotation of the shoulder along with the teres minor is the function, and it will be also an anterior shoulder pain with trigger points found in the region of the infraspinatus muscle, and the referred pain will be anterolateral arm, the medial border of the scapula, and the upper posterior cervical region. So it's part of that, again, the tendinitis spectrum of the rotator cuff, but we have to individually test for these also. And for infraspinatus, we do an aptly scratch test and compromised active range of motion with a full passive range of motion as same. And the impingement syndrome is the most common cause, as we found with the shoulder pain, with 44 to 65%. It may be due to a range of pathologies, and there is a difference between external and internal impingement. So external impingement is the impingement in the subacromial space, that is outside the shoulder joint, inflammation, irritation, any kind of degradation. Internal is within that. This is rotator cuff pathology or slap tears. The subacromial space is anteriorly bordered by the acromion and the coracoacromial ligament, the superiorly by the acromioclavicular joint, below by the humerus head. So there is a space, and in between that the supraspinatus muscle goes. So if there is any pathology in that particular space, it might cause compression, and this is the impingement syndrome. It is a part of the rotator cuff pathology, but it is have to be diagnosed with a Neer test or Hawkins-Kennedy test. And signs will be weakness of the shoulder abduction, external rotation, and tenderness over the coracoid process, and the sports activities like volleyball, swimmers, those people are commonly affected. And this is another rare cause of osacromial pain syndrome, is a failure of ossification of the secondary ossification centers of the acromion process. So it's commonly termed as a non-union. So failure of fusion of any of the primary ossification centers will lead to shoulder pain, and is localized in the anterolateral acromion, difficulty with performing overhead activities, and there will be localized tenderness, and present can have a differential diagnosis of subacromial impingement. So we have to do an X-ray and axillary view to actually diagnose this osacromial pain syndrome, and even in a post-surgery like failed back surgery, a failed arthroscopic subacromial decompression can also have this kind of feature. And pectoralis major tear is an acute event, particularly in weightlifters or in a bench press test. So pectoralis major starts from the costal cartilages, the sternum and goes to the, from the clavicle also, and goes to the bicipital groove in the humerus. So the nerve supply being these, and the adduction, forward flexion and internal rotation is the function, and it will be affected particularly in weightlifters. Trauma will be due to the excessive tension because of the contracted muscle will have some tension avulsion and at the site of insertion. And the tearing sensation or pop will be accompanied by a painful limitation of movement will be a symptom, common symptom. The swelling and ecchymosis over the anterior shoulder will help in the diagnosis, and weakness of adduction interrelation as a function will help in the diagnosis of pectoralis major tear. And suprascapular nerve starts with the upper trunk of brachial plexus, goes to, through the supraspinatus fossa, then supraglenoid notch, and it supplies the supraspinatus, infraspinatus, and 70% of the shoulder joint, sensory supply of 70% shoulder joint, and it might be due to a traction or a compressive lesion. Traction may be due to the transverse ligament hypertrophy or tension, and compressive lesion may be due to a vascular malignancy, vascular abnormality, malignancy, a ganglion cyst, or a space-occupying lesion. And the symptoms will be posterolateral shoulder pain, and if the compression or the pathology is in a supraglenoid notch, there will be isolated infraspinatus weakness rather than a particular shoulder pain. So we can differentiate there from the history and examination. And muscle atrophy may be there with weakness of shoulder abduction, internal rotation, and suprascapular nerve stretch test, where we actually do a traction where the opposite shoulder is, the patient is asked to see in the opposite side, and we put a arm was the posterior side. We press on that, so the suprascapular nerve gets stretched, and we can elicit the pain. And coming to the last syndrome of all, this is a quadrilateral space syndrome. So quadrilateral space, it is bounded by the teres major inferiorly, superiorly by the teres minor, laterally by the latissimus dorsi, and the medially by the latissimus dorsi, laterally by the humerus head. And it is content is quadrilateral space is a compression of the posterior circumflex humeral artery and the axillary nerve, and obviously the symptoms will be the poorly localized and dull aching pain in the lateral and posterior shoulder near the quadrilateral space, non-dermatomal distribution, and there will be point tenderness in the quadrilateral space, and common pathology is a fibrous band in the quadrilateral space, which might cause compression of these vascular and the neural structures. And because axillary nerve supplies the deltoid muscle, there will be might be weakness and atrophy of the deltoid muscle, and you have to differentiate from the other shoulder pathologies already mentioned. So this is the shoulder teres major and the minor, and this is the fibrous, and the white part is the fibrous band, which can cause compression. So these are my references. And I give my deep gratitude to Dr. Subrata Goswami, sir. May you live in our hearts and works forever. Long live your ideals, sir. Thank you. Thank you.
Thank you so much, sir. I'd like to invite upon stage Dr. Abhijit Banerjee to please felicitate Dr. Please felicitate Dr. Deepashri Bhattacharya. Ma'am, please come. I'd request Dr. Debanjali Ray to please come on the stage and felicitate Dr. Manish De. The next session is on relevant anatomy of shoulder pain. The session will be chairpersoned by our senior consultant and in charge of the Department of Anesthesiology, Pain and Perioperative Medicine, Dr. Amyo Kumar Mishra. To speak on the topic, I'd like to request Dr. Shushpa Das to please come on the stage. She's a consultant at Dardia Pain Clinic, Kolkata, with various publications under her name.
A very good evening to everyone present here. I will be describing the shoulder anatomy before we go into the details of sonoanatomy. A few slides showing the shoulder anatomy. So shoulder joint. Shoulder joint is a synovial joint, but it is comprised of 4 small joints, like 3 true joints and 1 pseudo joint. So 3 synovial joints are present, which are forms the articulating joints, and 1 pseudo joint. Why is it called pseudo? It's because it is basically supported by different muscles and structures around that area. So the synovial joints are the sternoclavicular joint, the acromioclavicular joint, the glenohumeral joint, and the scapulothoracic joint is the pseudo joint. Now, briefly describing all the structures forming the shoulder joint. So, the proximal end of the humerus is what we will be focusing on. So, the proximal humerus consists of the head of the humerus, then that is separated by an anatomical neck here, anatomical neck, from the greater tubercle and the lesser tubercle. So, the greater tubercle and lesser tubercle and in between these 2 tuberosities, there is the bicipital groove. So, from the bicipital groove, the bicipital tendon traverses. So, this is important for us when we see the sonoanatomy. We will be seeing 2 mountain-like structures, the greater tubercle and the lesser tubercle, and in between that area, we'll be seeing a depression which will be the bicipital groove. Now, the other bone which importantly forms the shoulder joint is the scapula. So, here in my slides, I will be talking about the scapula when we are viewing it from the lateral end, when we are viewing it from front, and when we are viewing it from the back. So, here the scapula from the lateral aspect. The important structures that we need to know in this lateral aspect is the glenoid surface, which is present and it forms a part of the shoulder joint. So, the head of the humerus is present near the glenoid, and as we see in this diagram that the glenoid is a flat surface and the head of the humerus is near that. So, in order to keep the head of the humerus, it has to have a rim-like structure near the glenoid labrum. The glenoid labrum or the ligament forms the rim-like structure which helps to hold the head of the humerus in place, and also it is supported by some other structures there. Another important thing is on top of the glenoid is a supraglenoid tubercle. Why is it important? Because the main muscle, the biceps muscle, the long head of the biceps goes and attaches over there at the supraglenoid tubercle. So, we need to know about the structure. Next is seeing the scapula from the anterior aspect. I will be talking about the important things that we need to know here. So, the scapula will have a medial border, a lateral border, superior border. Here in the anterior surface, we see the subscapular fossa. So, the subscapular fossa is important. Why? Because the subscapularis muscle takes its origin from this subscapular fossa, and it goes and attaches, the muscle goes and attaches out here on the humerus on the lesser tuberosity. So, the lesser tuberosity is present medially, and on the laterally we will see the greater tuberosity. Another thing here in the scapula, if we are seeing it from the superior surface, from the superior view, we will be able to see the suprascapular notch here, the suprascapular notch. So, from the suprascapular notch, the suprascapular nerve traverses. So, this structure is important. And we should know that from the anterior surface of the scapula, there is a projection which ultimately forms the coracoid process. And from the posterior surface of the scapula, there is the spine of the scapula which extends and forms the acromion. So, basically these structures are there to make the shoulder joint much more stable, so that the bone doesn't come out, or to provide the strength to this particular joint. Now, we want to see the scapula from the posterior aspect. So on the posterior aspect, some important structures are, first is the spine of the scapula, which extends and forms the acromion. Then above the spine of the scapula, there is the supraspinous fossa, which gives the origin to supraspinatus muscle. Below that is the infraspinous fossa, which gives its origin to infraspinatus muscle. So these muscles are important in forming the rotator cuff. So this again gives stability to the shoulder joint. Here, like I was speaking earlier, there is a suprascapular notch. This is the suprascapular notch here, and then there is a spinoglenoid notch which is present near the glenoid. So the suprascapular nerve will be traversing like this along with its arteries in this course. Next is the acromioclavicular joint. The acromioclavicular joint is formed mainly by the acromial, I will be covering this again later on. So basically it is formed by the acromioclavicular ligament. And this structure is important for us in cases of acromioclavicular joint arthritis. Next is the glenohumeral joint. So basically the glenohumeral joint is a ball and socket joint. When we talk about shoulder joint, we call it a ball and socket joint because it is formed by the head of the humerus and the glenoid cavity. So the glenoid labrum is an important structure because there is slap lesions or there is a tear in the labrum. And we should know that even though USG is very helpful for us in diagnosing different conditions, it is almost at par with MRI. But in cases, especially in cases of glenohumeral joint pathologies, we should be doing an MRI for the patient to find a definite diagnosis. So this is the shoulder joint overall. Here we will see that there is a synovial membrane which is covering the head of the humerus here. Then on top we will be finding the glenohumeral ligaments, the superior glenohumeral ligament, the middle glenohumeral ligament, and the superior, the middle, and the inferior glenohumeral ligament. So first the synovial membrane, then the glenohumeral ligaments, and then on top of that there is the capsule of the shoulder joint. Now coming to the different muscles which are present in and taking part in the formation of the shoulder joint. So main muscle, when we are doing the sonoanatomy, we will be seeing the deltoid muscle. The moment we put our probe, we'll be seeing the skin, subcutaneous fascia and subcutaneous tissue, and then we will be finding the deltoid muscle. So the deltoid muscle with its parts like anterior, middle and posterior part of the deltoid muscle will be seen. Then one important structure is the biceps. So the biceps muscle has two parts, long head and the short head. Our interest is mainly the long head of the biceps. So the long heads of the biceps, it goes and attaches. The origin of the long head of the biceps is from the supraglenoid tubercle, which is present above the glenoid cavity. Then this, once that it takes its origin, the muscle will come in a fusiform structure and it will come down. It will, along with it, the short head of the biceps will also join, and then this entire muscle body will come down and attach at the radial tuberosity at the elbow joint. Then the next important structure is rotator cuff muscles. So rotator cuff tendinopathy, as my speaker earlier has already mentioned, it is important for us to know that we have already read about this in our first year of MBBS. So rotator cuff muscle goes by the structures SITS. So first is the supraspinatus muscle, which takes its origin from the supraspinous fossa, which is present, which was seen on the posterior aspect of the scapula, above the spine of the scapula. Then there is this muscle will go and insert on the superior facet of the greater tuberosity, and its function is abduction of the shoulder joint. Next is our infraspinatus, which takes its origin from the name itself. We come to know it is taking its origin from the infraspinous fossa, and it goes and again attaches to the middle facet of the greater tuberosity of the proximal end of the humerus. Its function here is external rotation. Then is the teres minor muscle. It takes its origin from the lateral border of the scapula and goes and inserts itself on the inferior facet of the greater tuberosity of the proximal head of the humerus, proximal end of the humerus. So first is supraspinatus. S is superior facet attaching, inserting on the superior facet, then the middle facet, and then the inferior facet. And the fourth muscle is subscapularis muscle, which is taking its origin from the subscapularis fossa, and it gets attached at the lesser tuberosity on the proximal end of the humerus. Its function is internal rotation. In order to elicit the subscapularis muscle, we are supposed to do external rotation at the shoulder joint, and we will be able to see the muscle. Then this is, I've already discussed this. This is the rotator cuff muscles on the greater tuberosity. The superior facet, supraspinatus attaches, middle facet, infraspinatus attaches, inferior facet, teres minor attaches. And then on the lesser tuberosity, the subscapularis goes and attaches. Now this is the acromioclavicular joint. So the acromioclavicular joint, the patient will come and tell you that there is pain on, typically pinpoint pain at that particular site of the acromial. So basically we are supposed to palpate the area and put our probe and find out if there is any irregularity in the zone anatomy. So what we see is there are two ligaments forming the acromioclavicular joint. One is the acromioclavicular ligament and another one is the coracoclavicular ligament. The blood supply is by the suprascapular nerve and suprascapular artery and thoracoacromial artery, and the nerve supply is by the lateral pectoral and axillary nerves. Then the subacromial space, we see the, have to see the subacromial space on sonor anatomy to find out the subacromial bursitis, subacromial subdeltoid bursitis. As the name suggests, it is below the acromion and below the deltoid muscle. So what are the structures? Important structures present here is subacromial deltoid, subdeltoid bursa, coracoacromial ligament, and the supraspinatus tendon. So here, this bursa, the main function of this bursa is by the supraspinatus tendon movement. In case there is bursitis, the movement of the supraspinatus tendon will cause pain in the patient. Now, suprascapular nerve, there are obviously many nerves which are present in the shoulder joint. The ones clinically relevant, I'm talking about those. So suprascapular nerve that I've already said is accompanies the suprascapular artery, and on sonor anatomy, when we are keeping the probe on the superior aspect of the scapula, we will be finding it near a pulsating vessel. And for providing anesthesia, regional anesthesia will be blocking at this site, at this particular site, at the suprascapular notch. This nerve then traverses below and it gives articular branches over here, and it is also accompanied by the artery there. And here, in case of, if we are placing the probe just below the spine of the scapula, we will be finding the suprascapular nerve there near the spinoglenoid notch. So the spinoglenoid notch here, in case like we are blocking the nerve here, chances of motor loss is lesser than if we are blocking the nerve out here. Thank you.
That was a wonderful session. To felicitate Dr. Shushpa Das and Dr. Ramya Kumar Mishra, I'd like to invite upon stage Dr. Sanjay Patwari. Please. So with the anatomical knowledge that we have gathered, we'll move on to our next topic, which is USD demonstration of the sonoanatomy. I request Dr. Gautam Das to grace the stage as the moderator for the topic. He needs no introduction. Teacher of all the teachers, former president of ISSP, ex-editor, Indian Journal of Pain, director of Dardia, the Pain Clinic, dean of IAPM, and most importantly, the most famous teacher all over India and Indian subcontinent, with many publications in national and international journals and authorship of many leading books on pain management. To speak on this topic, I'd like to call on stage Dr. Chinmoy Roy, dedicated anesthesiologist and pain physician. He is a past secretary of the West Bengal Society for the Study of Pain and current secretary of the WBISA, who is dedicated for different organizational works at state and national level. So please. Dr. Chinmoy Roy.
So I learned ultrasound shoulder or ultrasound, I mean like in our practice in Dorodia only with sir. So now why we are learning this ultrasound? Why do we need? Because shoulder pain was there always. I mean earlier also shoulder pain was being treated by everyone. But now with time, I mean like there is no question of blind procedures, there is no question of imperfection. Everything should go, every procedure should be to the point and correct, at the correct place. Otherwise, if patient doesn't get better, then you don't know that whether procedure is wrong or the procedure was not done correctly. So that's why we are learning the ultrasound of, say today I am talking about ultrasound of shoulder, but it is applicable to ultrasound of any part of the body. And since we are not going to be a radiologist or reporting ultrasound, so we will target the specific areas and not the whole shoulder, like small things is not needed. So here a few things are important. One thing is that say which machine we are using and what is the probe. So here in shoulder ultrasound, it is mostly the linear probe we are using. Linear probe is important to do the ultrasound. Okay. Then patient position. Patient position is also important. Like in a wrong position, you cannot neither you can see well nor I mean patient will also become comfortable. I mean not become comfortable. So this is say neutral position. If I tell the patient to do like this in this way, then this will be the cross position. Okay. If I tell him to do like this, then it will be the modified cross position. So in a volunteer cross, modified cross, everything is possible. But in a patient, in a shoulder pain patient may not be able to do. Then you just say that do like this. This much is sufficient to see all the most of the structures. Okay. So most of the patient comes to us with say rotator cuff tendinopathy, shoulder pain like frozen shoulder also can come, but initially I find that most of the patients are in rotator cuff tendinopathy. So what are the rotator cuff muscles? We know supraspinatus, infraspinatus, and then teres minor and subscapularis. So all these four muscles are rotator cuff tendinopathy. And then ultimately what we are doing with this ultrasound, we are seeing the cross sections. So cross sections means it is like CT MRI only, like MRI cross sections or ultrasound cross sections, similar thing. In MRI it is like you see in two or three sections, axial, coronal, sagittal. Here we can make any section. In whatever way we will put the probe on the skin, that section we will see. So we are just seeing that what are the muscle layers. So here there are in shoulder there are two layers. One is from above and one is just below that. So just remember that here is the spine of the scapula. Here from the spine of the scapula and in the front side it is the clavicle. So in this area you will find the superior most upper layer is trapezius. Most upper layer is trapezius, and By the side of that, the upper layer is deltoid. Okay, so most upper layer is first deltoid, then trapezius. Below that, that is the rotator cuff muscle layer. So below that, this under the trapezius, we will find the supraspinatus. Under the deltoid, we will find the infraspinatus, teres minor also some part, mainly teres minor, and here it is the subscapularis. Though subscapularis not the full area is covered, but subscapularis also below that. Okay, so now let us see that supraspinatus. I first show you the one view that is most important for. So I will just hold like this, neutral position. Say it is neutral position. Okay, okay. Oh, another thing is in which side I am seeing. So this is the lateral side of the patient, and this is the this side, left side of the this one, your screen. So you remember that which side you are seeing and which side is the screen. That means when I will go more laterally, I will go more left there. Okay. So here two muscle layers we can see very clearly. We can see two muscle layers. I have to increase the depth a bit. Okay. So what are the muscle layers in this area? I know only two muscles. One is trapezius, one has to be supraspinatus. So when I am going more laterally, what will happen? There has to be a bone. There has to be a bone, and that is acromion. That is acromion. So this is the bone has come. One bone has come. What is there? So see here there is a bone. This is acromion. This is acromion. Again I am seeing showing you. If I I go medially, then see two layers. Two layers. One is trapezius. One is supraspinatus, and supraspinatus has a central tendon also. This is the supraspinatus. Somebody can say that okay. Somebody can say that why you are not considering this, that here is one layer, here is second layer, here is third layer. No, it is not like that. So that much we have to know, that this is one layer, trapezius, and this whole thing is the second layer, supraspinatus. This middle thing is only the tendon. So if I go more laterally, then we know that supraspinatus tendon is going under the bone. So it is going under the bone. As soon as it is under the bone, we see only the bone and not the muscle. So then if I come like this, then bone will finish. This bone is over. Okay, bone is over, and we are seeing muscle again. Okay, now if I put like this, then you see the movement of the head of the humerus. Movement of the head of the humerus. So this is the bone is gone, and head of the humerus is here. Okay, I will show again. So this much. Oh wait. I will decrease the depth here so that you can see it more clearly. Okay. So this is the bone, and here what we can see is the supraspinatus tendon. So this is the supraspinatus tendon. Once the bone is gone, this is the supraspinatus tendon. Wait, I am not being able to see you the. Okay. So this is the bone and this is the tendon. Okay. So this is the tendon. So now, if he moves. For showing purpose, it is better. I mean, this gives a more book picture type of thing. Okay, so okay, just freeze. No? Okay, so here you can see that this lower part. This is the supraspinatus. This is the supraspinatus. And this is the acromion, this is the acromion, and this is the head of the humerus. This is the head of the humerus. Okay, this part mainly, this is the head of the humerus, and this is a bird peak appearance just coming in the into its insertion, greater tubercle, and this side it is the deltoid part. This side it is the deltoid part. So here few, I mean, why we need to see this view? We need to see if there is a supraspinous tendinosis, then problem will be here. Here he is not a patient, so this is, you can see that very clear, very, I mean, like shiny fibrous tendons you can see. But if he would have been a patient, then you would have seen two things. One thing is that this tendinous structure will become a bit black colored. I mean, like it is hypoechoic. In our ultrasound term, it is hypoechoic. So it will be dark, and associated with this dark part, there you can find some cortical erosion. Then we will say that this tendinosis is more likely, because cortical erosion is also there, and this hypoechoic part is also there, and this there can be a bit swelling also. Also it can be possible. So this is one thing for supraspinous tendinosis. We want to see that this view. Then second thing is subacromial subdeltoid bursitis. So that is also patient will present like this only, lateral side pain. So here there is a structure between these two muscles, two layer of muscles. You can see these two color for two muscles. There is a small black line. Gradually we can see within this white. This is a static picture. I will show you again. So within this white line, there is a very fine black line. This black line is the target for subacromial subdeltoid bursa injection. So remember, earlier we used to do many people used to do now also many people does blind injection. Can you I mean, imagine that your needle without seeing will stay here? It will never stay. Either it will go within the muscle, or it will be in a wrong injection. So this type of injection has to be done under the ultrasound only. Otherwise this fine bursa you cannot see. So this is important for two entities. One is subacromial subdeltoid bursitis, and another is supraspinous tendinitis or tendinosis. Okay. Freeze, unfreeze, yeah. Rotator interval. Okay. Rotator interval is a bit, I mean, like advanced part. Okay, just so see this part again. Here within this black line, you need to have it is 13 Hertz. So yeah, freeze. Okay, more if your resolution is more even more than 13 Hertz, then only you can see. So this is the line. Some part you can see. So this is the line, black line within the white line. So with more resolution, you can see that this line is coming like this. This is a big bursa. This is not a small bursa. So this is the line. Okay. I show you again. Just try to see here, which I have shown just now. Okay. So yeah. So here you can see black line within white line. Okay. So this is the line. Many times I have seen, even in YouTube videos also, sometimes I have seen that people do not give injection in the right part. Here, okay, just freeze please. See, if you try to find lines, you can find line here also, here also. But these lines are not correct lines. Lines are within this black line in white part. That is the correct line. If you give in a wrong place injection, then it will just split one layer of muscle fibers, and the spread is not correct. And if you are in the right place, then fluid will not remain in the same area. It will split both the muscles, I mean up and down. Okay. So this is one thing. Okay, this is supraspinatus, and okay. Say next another our entity which comes to us is say AC joint pain, acromioclavicular joint pain. That is more or less in arthritis patients you get acromioclavicular joint pain, but AC joint is very easy to find. So this is AC joint, okay. This is AC joint. So here you may get a bit confused that which one is what, which one is clavicle and which one is acromion here. So you go towards lateral side, then acromion can end there, not the clavicle. So you know this is the acromion, and you again go there. So this is the clavicle. This is the clavicle. This is the AC joint. Okay. So AC joint injection most of the time you don't have to go with the beam. You go from outside the beam, just from the side. So this is the AC joint. Okay. And never try to find. So what do we see in AC joint? So it is like any other joint. Arrow. So any other joint, first thing, here there could have been some osteophytes. Here there is no osteophyte since he is a volunteer, but there could have been some osteophyte. There could have been some effusion. There could have been some effusion. There could have been some instability. How we will see the instability? Just with the movement, these two levels, this is clavicle, this is acromion, okay. The cortex level, both the cortex should be in one line. With movement, if it goes more than 1 centimeter, any side, acromion side or clavicle side, with movement goes more than 1 centimeter, then you know that there is a instability. Maybe the acromioclavicular membrane is ruptured, or I mean like with degeneration also, with this type of movement. Okay. So here movement is there, but it is not moving much because he has a good AC joint. Okay. And acromioclavicular, this one is the membrane. Upper part is this one is the membrane. So this is normal AC joint. So we see in this way. Many people have seen that AC joint, sometimes they want to see from front side. It is not from the front side, okay. We just keep like this. So this is AC joint, this is AC joint, okay. So these two things, important things. Another thing is that suprascapular nerve. Suprascapular nerve actually we don't need nowadays. Earlier we used to do for some shoulder pain. But now when we know that pathology is not from the nerve, pathology is from somewhere else, why we are numbing the nerve? If we numb the nerve anywhere, patient will become painless, but for how long? We are not targeting a motor nerve anyway. So, but then still suprascapular nerve, we are able to find it. So, is in some conditions are there where I mean say there is some compression and suprascapular nerve is compressed due to compression neuropathy and all. So in that case you can give some steroid injection and it can go for you can treat suprascapular nerve neuropathy, or if pulsed radio frequency, of course you can do. Remember, nerve is not always under the that membrane, suprascapular, transscapular membrane, it is not under the membrane. Artery and vein is under the membrane, but nerve can be above that membrane. Okay. So here suprascapular nerve is, here there is a triangle formation. One bone has come this side, one bone has gone this side. So here just we keep and you see the, so there is a gap. Okay. First let us see that it is actually quite deep. It is quite deep. So this is a bone. Okay. Don't, I mean that white line is artifact. Don't go by that. Below this white line, there is nothing. These are all artifacts. Okay. So here this is the scapula cortex. So here when I am putting like this, so you can see the whole cortex. Very nice cortex. Okay. If I move a bit, so you see a break in the cortex. So this break in the cortex is the area of our interest, this target. Okay. So here in the target, you need much more resolution. So here in the target, artery is there, okay, pulsating artery, you can see one pulsating artery, okay, but clear nerve we cannot see. So one artery you can see, pulsating artery. So just above that, here it is pulsating, okay. So this area, this is the suprascapular artery is coming here, I mean like this is still not in the fossa, but it is just entering. And this is our target, that here only we will see the suprascapular fossa. This is the bone, intact bone, and if I just move it, this is the intact bone. So his fossa is a bit different, but then this is the area where this is the suprascapular fossa, and you can see the artery only, pulsating artery. That's it. So I mean like for putting, if steroid injection you want to give, you can give the injection there only, and if you want to put a called pulse radio frequency on, then first put the needle and do stimulation. There will be sensory stimulation or motor stimulation. So and 2, 3. Okay. So other things like bicipital neuritis can happen, but very less common. So this is the bicipital groove. This is the bicipital groove. Laterally you come, so this is the greater tuberosity. Medially you go, this is the lesser tuberosity, lesser tubercle, greater tubercle. Between the between these two tubercle, this is the biceps tendon. This is the long head of biceps tendon. Remember, this is not short head. This is not short head, okay? And you have to decrease the depth, okay? 2 tuberosity, lesser tuberosity and greater tuberosity, okay? So this is the bicipital groove. Within this groove, there has to be a tendon. So here it is hypoechoic black. So you may think that okay, maybe tendon is not there. So it is just a artifact. If I move it a bit like this, if I tilt my probe, it becomes again white. So this is the clear tendon, hyperechoic tendon structure, okay? So this is the tendon. And in this area, if I go more, so remember, you want to see the, okay, medial side there is a muscle. So this is the subscapularis muscle, and it is going under the acromion. So this is the acromion and this is the subscapular, coracoid, not acromion, coracoid process. So this is the coracoid and this is the subscapularis, okay. So if I do the external rotation, then whole muscle will come out, okay, whole muscle will come out. This is the subscapularis muscle, in this way. And if I do like this, then this subscapularis muscle, you can see it is inserted in the lesser tubercle and it is coming out and going in, okay. So here also some impingement can occur. Here also under the coracoid process also some impingement of the subscapularis can occur, okay. So this is another area, and you wanted to see the this one, rotator cuff interval. So rotator cuff interval is what? Rotator cuff interval means shoulder joint, it is covered by the rotator cuff in every area, only one area is missing. So that is called rotator cuff interval. That is one area is like there is no 2 layer, only one layer, only one deltoid, and second layer is missing. Second layer is some fascia type of thing. So if you just puncture one layer, you are inside the joint. So that is called rotator cuff interval. So here rotator cuff interval, first what you do, so bicipital groove, start from bicipital groove, okay. So here after reaching this much area, bicipital groove should end, bicipital groove has ended. Okay. Now one side I will, the acromion side, the lateral side actually, coracohumeral ligament, এটা দিয়ে দেখা যাবে? Okay. 13, okay. Okay. So here, bicipital groove, I have come up to this much, bicipital groove is there. So here I understand that one side subscapularis, supraspinatus is coming from this side. So I will just rotate my probe in this way so that both muscles can be seen. If both muscles is seen, then this is the picture. Then this is the picture will come. It's become dark. Okay. Anyway, freeze. Okay. So these two muscles have come, and here bicipital groove is over. So what is this muscle? No, this side, this left side, this is the supraspinatus. What is this muscle? Subscapularis. And they have not inserted. At present, it is not at the insertion, a bit above, a bit above. This muscle is also going, this muscle is also coming like this. So a bit above part, and this is the, these are the borders. These are the borders. I mean, like here, subscapularis. I mean, this is a just concept that biceps tendon is coming and entering like this. One muscle is like this, one muscle is like this, and in between, say this is the biceps tendon. So one muscle in this way, one muscle in this way. I am cutting here. Okay, so you see the picture. So one muscle here, left side, one muscle here, right side. So any injection at this area will go directly in the joint. Okay, any injection will, this area will go directly in the joint just by the side of the tendon, by long head of biceps. This area is empty. I mean, like this is continuation with the main joint area, synovial sac. So whatever you will give, the immediately joint to fluid will go inside the joint, and it will not become, I mean, it will not deposit there and form like this. If you see that anything is depositing, then you are not in the right place. Okay, it should go inside. And second thing, so what are the ligaments? Small part. Say, so if we consider from deep to superficial, then first is bone. And what is ligament? Ligament is nothing but thickening of the capsule. So bone, then ligaments from deep, no, so ligament, then comes muscle, then comes bursa, then comes skin. So when we will put the ultrasound probe like this, then I will try to search the ligament just above the bone. So what I will search, that is the glenohumeral ligament. So here, just in this area, here should be glenohumeral ligament. But then there is another ligament, that is coracohumeral ligament. Coracohumeral ligament we will find here above subscapularis. Above subscapularis muscle, we will see one ligament. From coracoid side is this side, medial side. From there it will come, some fiber will join in the medial side, some fiber will go in the lateral side. No, I am showing coracohumeral. Coracohumeral, some fiber medial side, some fiber lateral side. Over the long head of biceps. হ্যাঁ, সেখানে দুই সাইডেই যায় ফাইবার, both side fiber is possible. Okay, so I show you here. So here subscapularis is ending. This is the coracoid process. this one is the coracohumeral ligament. So just freeze it. I can, if I decrease the depth, okay. So I will show again, just see this part. So this part, this is a ligament. This is white, very hyperechoic ligament, okay. This is subscapularis muscle, okay. So this is a ligament coming from, this is coracohumeral ligament. Here is the coracoid process, subscapularis, coracohumeral ligament. So this will come and joint in the lesser tuberosity, but some fibers will cross and go to the opposite side also. Okay, if I decrease the depth, then I will be able to see, increase the depth, then I will be able to see a bit more area. So here you see, so now we can see the coracohumeral ligament in a much clear way. Okay, see the ligament, whole white colored ligament, the rope type of ligament, it is the whole coracohumeral ligament, okay, coracohumeral ligament. It is so, I mean, literature wise, I show you. You want to see the thickness as a proof of frozen shoulder, but I mean, like, there is no good evidence that it is very specific. You will show in this area, This is the thickness area. This is only, it is shown that I mean, thickness increases. Just yeah. Okay, so this area, just say 1 centimeter, 1 centimeter distal from the 1 centimeter lateral from the coracoid. But frozen shoulder, I mean, I have seen so many literature. Somebody says coracohumeral ligament is thickness increased. Somebody says glenohumeral ligament thickness is increased. But I will not say that. I mean, there is no good evidence. Yes. Whether this ligament is really increased or not, you cannot say clearly. Okay. So,
Dr. Chinmay, we have to.
Okay,
faster.
please. Yeah.
To go faster.
No, I think it's okay. I mean, the important things I have shown, which comes every day. Other things you can go on. Yeah.
Thank you, Dr. Chinmay, for that was an awesome demonstration. And often posterior shoulder. So we must learn how to scan posterior. Okay. For that, I would like to
So this is a video clip. So first layer of the muscle, if you are scanning there, that is your So mostly Orgo told me to show the 3 occipital nerve, greater, lesser and least. But for that also we must know the different muscles. So first is your the strap muscle, very superficial muscle is your the trapezius, and this is a very thin layer of muscle. And if you are removing the trapezius, so then 2 important muscle will come. And the midline, particularly in the occipital area, this muscle is your semispinalis capitis muscle. And if you are going little bit laterally, this is your splenius capitis muscle. First is your trapezius, and after that on the midline we are having the semispinalis, and if you are going little bit lateral, we will be getting the splenius. And now if you are removing that, so after you are removing the semispinalis, so few other muscles will be coming. So from the occiput, this muscle is your rectus capitis posterior minor. Rectus capitis posterior minor is exactly on the side of the midline, almost vertical, and it is from the occiput to the arch of the C1. So this muscle, occiput to the arch of the C1. That means if you are scanning it, holding the probe coming from the midline below, then immediately below the semispinalis we will be seeing the small muscle in the midline, that is your the rectus capitis posterior minor, and that is ending at the level of the C1, arch of the C1. So now if we are going little more down and laterally, by the side of the rectus capitis posterior minor, we will be seeing this muscle. This muscle, look, this is oblique. This is your the rectus capitis posterior major, just lateral to that. So origin insertion is occiput to the C2 spinous process. C2 spinous process, how to know that this is bifid, first bifid, and the slope is very steep. Arch of the first is arch of the atlas is rounded, but as you will be coming down, the first bony slope what you will be getting, that is your lamina of the. By looking at the arch itself, you will be understanding that this is the C2. Many literature says that you will be getting the bifid spinous process, but sometimes it is very difficult to identify that whether it is a bifid or not. But still more very clearly visible is your suddenly a deep slope will be coming, that is your arch, that is the lamina of the C2. So these 2 muscles both are obliquely oriented. Medially is your rectus capitis posterior major, and another is your rectus capitis posterior, it is your obliquus inferior. So obliquus inferior origin is your C2, and it is inserted into just below the, this is, what is this muscle? Splenius. So below the splenius capitis, from the C2 to the transverse process of the C1. And these 2 muscles are very important. Means we will be getting the greater occipital nerve here, above the obliquus inferior. Laterally, the very big nerve will be your the greater occipital, and if you are going little more medial, we will be getting the lesser occipital. So let me try. Here this video, the important is to see the nerve, we should be having a very high resolution probe. So here unfortunately we don't have the high resolution probe. Here the resolution of the probe is only 13. So at least 18-20 megahertz probe, otherwise it is very difficult to distinguish all these nerves. But still, let me try. ঘুরিয়ে দাও, ওইদিকে মুখ করে দাও। তুমি মাথাটা এখানে রাখো, ঠিক আছে? So my aspect marker is on the left hand side, and I am starting scanning here, occiput, and then gradually I am coming down. So this black area, this is your very thin layer of the trapezius. And the muscles, so here this is your trapezius, and this muscle is what? Midline semispinalis capitis. Now I am coming down here, the very small muscle will be appearing, that will be your rectus capitis posterior minor, just below the semispinalis, close to the midline, and here will be coming rectus capitis posterior major. Okay, so this muscle is your, now below the semispinalis, so what you can see here after the trapezius, semispinalis, and this muscle, again resolution is not that very good, I am sorry. So here is your rectus capitis posterior minor, and here is posterior major. And now the arch of the C1 will be coming, and when I am coming still down, as I was telling, I will be getting the C1. একটু এই জায়গাটা রেজলিউশনটা বাড়ানো যাবে, ডেপথ। So this is your lamina of the C2. So what I was telling you, as soon as you will be getting the very steep lamina, so you know that this is C2. So I was here, so this muscle was your rectus capitis, this is your C1, arch of the your C1. This muscle is getting inserted, here is your rectus capitis posterior minor, here is your rectus capitis posterior major, this was your semispinalis. If I am going on the lateral side, this is the rectus capitis posterior major, and here still laterally, this is your splenius capitis above the semispinalis, and here will be coming your sternocleidomastoid. This is your sternocleidomastoid. So this muscle, what is that? So this is the, what are the muscle here? Semispinalis capitis, this is your splenius capitis, this is your some portion of the your sternocleidomastoid, and this is your longissimus. So normally we get it here, the lesser occipital nerve, just medial border of, here you can see, but again high resolution probe can show the lesser occipital nerve better. So this is your lesser occipital nerve. Depth kamale, but still looking at the nerve here is difficult. Most likely this is the nerve. Most likely this is the nerve. Here we will be getting the nerve. This is the sternocleidomastoid lateral edge. This is your splenius capitis. This is semispinalis capitis. This is your longissimus. So now again coming here, and I am searching for the C2. So this is your C2. As I told you, C2, you will be knowing it, the bifid spinous process and slope. And this muscle is what muscle? This muscle is obliquus inferior. Obliquus inferior. And above that is your, what is this muscle? Semispinalis. And in this plane we will be finding the greater occipital here and third occipital here. So now how the obliquus inferior is oriented? It is from the spinous process of the C2, it is obliquely. So if I am holding the probe like this, you see now I am seeing this obliquus inferior in the long axis. So this is your obliquus inferior in long axis, and here we will be seeing this is a greater occipital nerve. Greater occipital is very big now, and here we will be seeing the lesser occipital nerve. Again, good resolution probe, but here it is seen very nicely. This is your greater occipital nerve in cross section. So if I am holding the probe like this, one end of the probe is C2 spinous process, another end of the probe is the C1 transverse process, then these fibers of the, this is your greater occipital nerve, this one. And this is your long axis obliquus inferior. Now, if I am just rotating the probe, you see what is happening to this occipital nerve. I will be able to see this nerve in long axis. Can you appreciate? Now, I am in the cross section, the two muscles I can see. See, my probe is, so this is the long axis greater occipital nerve. So now I can see this obliquus inferior in the short axis, and this muscle is your what? Rectus capitis posterior major in short axis. Because rectus capitis posterior major and the obliquus both are in this direction, oblique direction. And when I am holding the probe like this, I am seeing both this muscle in short axis, and I can see the greater occipital nerve in the long axis. And if I am coming here, this is your third occipital nerve. This is your third occipital nerve. So medially third occipital nerve, laterally it will be the greater occipital nerve. So this muscle is your what? Short axis of cross section of the obliquus inferior, and this is your rectus capitis posterior major. Okay. Thank you very much. Laptop.
Thank you so much, sir. It was a wonderful session. I'd request Dr. Shubhrata Roy to please come on the stage and felicitate Dr. Chinmay Roy, Dr. Gautam Das, Dr. Ashrukona Mitra, Dr. Rita Pal, and Dr. Jayanta Bhattacharya. Dr. Chinmay Roy. Dr. Ashrukana Mitra. Ma'am, please. Okay. Dr. Rita Pal. Dr. Gautam Das. Dr. Jayanta Bhattacharya.
Yes, thank you. Before we move on to the last session, I would like to show you something. So tomorrow is the day for ISSP 40th anniversary, and that is the 9th of this month. And let's see from West Bengal who are the president from in ISSP. So here you can see the list as published by ISSP this year in their newsletter. And we can see starting from the Dr. Ila Ghosh, and then Dr. Shondha Saha, then Dr. Vibhukalyani Das, then Dr. Professor Manjusri Ray, and Dr. Gautam Das. They were actually elected from the West Bengal to ISSP as a president. So please give a big hand for them all of them. Only Gautam sir is here. All others are not here right now. So that's why special felicitation were kept, but unfortunately all others were absent today. So anyway, thank you. We are move on to the last session of today, and that is a panel discussion.
Moving on to the most anticipated session, where we'll be learning from our experts a panel discussion on management of shoulder pain. To moderate the session, I'd request Dr. Sanjay Patwari, Senior Consultant Anesthesiologist and Pain Physician, past Secretary of WBSSP and current Secretary of WBISA, dedicated to different organizational works at state and national levels, to please grace the stage. Our team of panelists include Dr. Sameer Basag, anesthesiologist and dedicated pain physician, Southeastern Railway Hospital, gold medalist in IAPM exam, and now a faculty member in fellowship program there. Dr. Piali Boshak, physiatrist and pain physician. She has received Professor Ashok Saxena Award for paper presentation at 34th ISSP CON, published many papers in index journals, and currently working as in ESI hospital. She is a part of EC committee of WBSSP. I'd like to welcome Dr. Shrabani Sarkar, FIPM with specialization in musculoskeletal ultrasound and fluoroscopic guided pain intervention. She's a consultant anesthesiologist and pain physician at Arjikar Medical College and Hospital, Kolkata. Dr. Sandeepan Hazra, physiatrist and pain physician. She interested in neuro rehabilitation and pain medicine. He's assistant professor in NRS Medical College and Hospital. I'd request Dr. Orgo Mukherjee, our senior consultant from the Department of Anesthesiology and Perioperative Medicine and Pain Management and Palliative Care, to please take over.
Thank you. Thank you, Dr. Ria, for your kind introduction. So let's start with the panel discussion. As in the evening, we have seen three patients, three different kinds of presentations of the patients. So if we recapitulate one patient, he actually said he had a fall and trauma followed by pain on the left side of the shoulder. And second patient, he was operated and he lost one limb, and that is the desarticulated from the right shoulder, and followed by he started phantom limb pain. Straight away he pronounced the name phantom limb pain. He was quite aware of that thing. And the next patient was a mixed kind of fleeting kind of pain he presented with, and he said sometimes it is radiating, sometimes it is not present, sometimes it is localized. So it's a fleeting kind of character of pain was there. With those background, we start with this panel discussion, correct? So my first question, these questions, the first round of questions will be regarding the investigations of these kinds of patients. So my first question is, what are the investigations you want to advise to these kinds of patients, to Dr. Somesh?
Hello. So, this is the very good topic for discussion, that the shoulder pain, as we know, it is the acute or maybe the chronic. In both cases, we have to rule out the serious, the red flag of that. If there is some condition that arise not from shoulder joint, not from glenohumeral or external glenohumeral joint, that is origin from the cardiac origin, from the diaphragmatic irritation, we have to rule out all these condition before by clinically and by investigation. So for this, the basic investigation like X-ray of the shoulder joint to rule out the acute trauma or like the fracture or this kind of condition. This may be the fracture of the humerus, the joint and the clavicle and the surrounding stuff. And associated with this, we have to also do chest X-ray and ECG if there is complaining of also chest pain. So we have to undergo the basic investigation, and if the patient is shoulder joint symptom generally develop in patient with chronic diabetes and long-standing hypothyroid. So also we have to do blood investigation and the nature of the chronic illness, like long-standing diabetes at what level it is treated or untreated. So we have to do the basic blood test, complete blood count, ESR, C-reactive protein,
and what kind of specific investigation you do?
Specific investigation, like if there is the shoulder joint pain may not be the origin from shoulder joint, maybe some neck pathology may be there. So we have to specifically maybe go for electromyography test, EMG or NCV.
Correct.
And to rule out the other condition, not from, we have to see the joint above and below of the shoulder joint to rule out this type of condition.
Okay,
so
thank you. So, and obviously you have seen the ultrasound nowadays, and we will do ultrasound at our clinic only, in OPD clinic, if it is possible and available. Coming to next question.
I will little add to this.
Yeah,
if it is first of all, clinical diagnosis is much more important, but we have to differentiate whether it is a referred pain or it is a radiculopathy. For that only we have to judiciously use the investigations. We will not come the patient and do everything. So if there is a radiculopathy, then first we'll do the lesser cost test like NCV. If there is anything, then only we'll go for cervical spine of MRI. Otherwise, we will clinically treat the patient. By before that, we have to do whatever the Dr. Shamit Prasad has told.
Come to second question. Back. First, go from the first slide. Go back, go from the first slide. Take it out. Sorry for the interruption. That was a technical glitch. So yes, we were discussing about excluding the cervical spine causes. So my next question to Dr. Piali Shall you go for EMG and NCV before going for MRI?
There is a, not always, like if there is a, by clinical examination, if you find then there is a specific cause of the pain is shoulder, coming from the shoulder, then you can do directly the MRI. Why to go for the NCV and EMG? If there is a referred pain or kind of radiculopathy you are suspecting, then only you should first go for the EMG, NCV and then for the MRI later on.
Yes, correct. But I was talking about MRI of the cervical spine. So when there is a radiculopathy kind of complaint, shall you go for EMG, NCV first or directly go for MRI, because MRI is a costly?
Yes. So we can do that before EMG, NCV.
Yes, because sometimes even the entrapment syndromes are present in one hand, or in shoulder impingement syndrome, nerve impingement is also there. So it can also look like a radiculopathy. So there is a possibility of. Next question.
So, but with EMG and NCB, we cannot identify the pathology, where is the exact location, anatomical location of the pathology. So for this, we have to, of course, go for.
Yes, the definitive investigation is obviously MRI, but we can get some idea also. Next question.
Sometimes MRI also, I have a, in my mind, it came just now. There is a clinical presentation of a patient having shoulder pain. And obviously neurosurgeon came to a neurosurgeon actually first, and they did all the MRI, cervical spine MRI and then shoulder MRI also, and everything was normal. Then it was like we don't understand what is the cause, but there is a scapular muscles, like scapular stabilizer muscle weakness was there. So I ordered EMG first, and followed by I ordered the brachial plexus MRI, and then I found the cause. There is a neuropraxia of the brachial plexus. So sometimes you have to see
complexities are there. It is not as easy as that only radiculopathy from the compression of the radicals there in the neck. My next question is, what are the common treatment modalities available for shoulder pain to Dr. Saboni?
The patient, when he is coming to the clinic, we have to see whether the pain is acute or chronic. So if the main treatment for the shoulder pain is basically physical therapy, but if the patient is having acute pain, we will try to decrease the pain first and then encourage the patient to do physical therapy. So for the acute pain relief, we can use NSAIDs, the common NSAIDs which we are using, and along with that physical therapy should be, the patient should be encouraged to do any physical therapies. And also according to we have to find out by clinical examination and through thorough history taking, we have to come to the provisional diagnosis and treat accordingly. And if there is any tear or like that, then we can go for like local steroid or physical therapy or PRP newer treatment which has been present.
Thank you. My next question to Dr. Shamir again. You are using PRP for shoulder pain. How do you standardize PRP? Because there are several kits available in the market.
Sir, for this PRP, because the standardization meaning as a method by which we can reproduce the same concentration concentrated platelet repeated times. This is the standardization. So for this standardization, we have to use some fixed machine and fixed protocol. So our protocol is we use citrate, 2 or 3 cc citrate and 17 cc blood, whole blood. After that, we use fixed machine, that is the Alta PRP, that is Remy Alta centrifuge, and they have the fixed protocol, first spin and second spin. First spin is 1200 to 1400 RPM, and acceleration and deceleration are the same in the same machine. They have fixed their method, and then come to the second spin for the platelet concentration. For platelet concentration, the spin is 2800 RPM to 3200 RPM. So this is the fixed amount, the rotation, acceleration and deceleration. So, and the temperature is 22 degree. That's why we use F1 to the pre-cooling method. So all this.
That means you are always keeping fixed this all spin,
and all Dr. PRP kit. So with all this method, we are getting repeated time, same concentration. That is the 3 to 5 times concentrated.
Okay, I understood. Dr. Sandeepan, in Arjikar, you are a hell lot of PRP. So what is your protocol?
G. They are actually the G. They are radius and the spin is different in some machines. So they are using the 240 and 300G. First one is 300G and another one is 240G. And another thing is that after that, one thing can be done is that cell count. Cell count is a definite method by which you can also differentiate between the leukocyte poor and leukocyte rich, leukocyte deficient PRP, and by that way you can also use the activated PRP.
Correct. So every time do you
every time it is not possible. Actually, it is kind of research purpose. We can use that, but every time he is telling that it is that the same method, same spin. It is we are doing the same.
So you are again sticking to the fixed protocol.
Fixed protocol.
Okay. Next patient coming to you only. What kind of interval do you prefer between the two injections? What kind of interval do you prefer?
1 month.
1 month. It is a fixed protocol for you?
Almost fixed.
Dr. Shamir, is there any difference of opinion?
Sir, for the condition, the different types of condition we use PRP, but no,
we are discussing only shoulder pain.
Only shoulder pain.
I mean, it's
because if it is due to adhesive capsulitis, or it is there if there combination of adhesive capsulitis with partial tear. So first we have to treat not only pain but also restriction of the movement. This is the most important. So according to the DASH score, we have to assess the patient, and if there is restricted movement and pain, we have to treat the patient movement and pain. For this reason, we drew the two intra-articular suprascapular nerve block along with
I am coming to that.
Intra-articular and we SCHD injection with steroid. After the first sitting, we then go for PRP. Then we use PRP in 2 doses at 1 month interval. But at initial period, we are not use PRP.
Okay, that means in the second injection you are using PRP. Then after doing the PRP, what is the interval for second PRP?
It is generally 1 month. We take 1 month.
Okay. Any difference of opinion in the house? Anybody is using any different interval, different protocol? Okay. So the next question to Dr. Piali. PRP actually doesn't cause any pain relief, correct? So patient has come to you with pain, and if you inject PRP, it will not relieve any pain, and on the top of this, you cannot use NSAID, theoretically. A strong NSAID cannot be used. So then what is your regimen for analgesia? Because patient has come with the pain, he needs a relief.
Sometimes we use tramadol.
Okay.
We can use.
Okay, use tramadol. Any difference of opinion?
Paracetamol, tramadol, and cold compression.
Any difference of opinion?
Sir, we are basically using weak opioids like tramadol, paracetamol 1000 TDS can be given, cold compression, and this is mainly which we are using.
Okay. Then I don't use paracetamol also.
Okay, so that is the difference.
Sometimes it is a chronic or like lot of pain, then tramadol patches like buprenorphine patch also can be used.
Okay, fine. Any difference in house of usage like that? Next. So here we can use RFA also. When we are injecting PRP, we can use RFA or suprascapular nerve to relieve pain also. Can you use that?
We can
Pulse
use
radio
that.
frequency?
Pulse radio, we can use.
Okay, fine. Coming to next question. Did you face any allergic kind of reaction even after autologous PRP injection?
Sir, in our case, one knee joint, we injected for knee joint. That patient was high level of IgE, almost 900.
Did you know that beforehand? The patient had high level of
this
IgE?
patient was on Montelukast.
Okay.
She told us that my IgE level is high.
Okay.
And we use PRP because it is autologous.
Yes.
After that, patient developed knee joint swelling and erythematous area
Yes.
for
Yes.
few days, and we use application of ice and continue the Montelukast. This resolve within 3 to 4 days.
Did you use steroid?
No, we have not used steroid, and
Okay.
it is resolved within 3 to 4 days. And Again, after that first dose, we have used given second dose, but during that time, she does not develop any allergic reaction. But now, she
Okay,
is
I understood.
good.
Any
after
difference
2
of
dose.
opinion? Did you find anything like this? No, not really. Okay, coming to next question. This question to Dr. Sandipan. Do you think full thickness rotator cuff tear to be treated with PRP injection?
Probably no. Partial thickness tear is the ideal situation.
Okay, okay. Why I am asking these questions? Because in orthopedics, in the textbook of orthopedics, even it is written conservative treatment can be done initially even with full thickness tear.
Actually,
correct?
sir, the thing is
no,
that
I understood. I understood your ethics, and you said no, it's no. Any difference of opinion?
no, I just want to add one thing.
Articles are there, but
Sir,
very few articles are there even in complete here we can use PRP. Now the articles are coming.
yes, yes, yes. That's why I am keeping the question. Yes, sir. Hello.
Full thickness tear can be complete tear being if this area is retracted, then it should. But if it is a complete tear without retraction, then PRP works.
Yes, even with in retraction surgery also is very difficult. Arthroscopy and this kind of surgery, it is mentioned in the literature, they are very difficult.
Actually, I want to add one thing that
Sure.
it is the standard textbook teaching is that if it is depends on the age and profession of the patient. If it is he or she is a elite athlete, then you should go for the surgery. If
Correct.
it is a sedentary individual, is office goer, then you should go for the conservative treatment for any kind of tear in the superspine.
Yes, actually. So, yes. I think.
Regarding surgery, you are talking about retraction. With modern technique of arthroscopic surgery, even in retraction, you can use anchors. Other than suturing the two ends, you can use anchors and fix it. And I have seen patient with a total complete tear. If, after repair, they not only their mechanical function improve, they also become painless most of the time. Though literature says the outcome after 2 years, 3 years is same
very
in
guarded
conservative pain.
and something. Yes, thank you.
Installation of therapy after doing the arthroscopy.
Yes. Next question to Dr. Saboni. We have already talked about this. Would you like to perform RFA in shoulder pain?
If the pain is not subsiding with the conservative management, and if it's like if the patient is having osteoarthritic changes and having restriction of movements and chronic pain is there, then we can go for radio frequency ablation.
Thank you. Next question. Yes.
For the shoulder joint pain, I have searched in so many articles. Also, in everywhere it is written that no protocol is standardized. That we can use this one and that one. Even after surgery, patient also develop same type of problem. So nothing is definitive that it is the protocol. So if it is it is a practice, it is a method which you are doing. If with the conservative management, it is not improving with the first RICE protocol and then conservative management, then physiotherapy, then we go for USD guided procedure or this intervention procedure. But RFA should be preserved as a last resort. If all other methods is fail.
By protocol, I mean to say institutional protocol, local protocol like this.
Yes.
And orthopedics protocol is obviously different, and we are not going into that. Did you feel any role of dextroprolo, Dr. Piali, in shoulder pain?
Sorry to say, I don't practice this dextroprolo.
The question is there, do you feel any role of dextroprolo in shoulder pain?
There can be, but I don't practice.
Okay. In house, anybody is using dextroprolo? Which kind of, if you can? What kind of
in a
dextrose
volleyball
you are
player
using?
with rotator cuff trauma, I have used 5 doses of dextrose therapy, but the pain relief was good. for 3-4 years. After that, again, pain reappeared, and then I prescribed exercise and referred them to the orthopedician. But at that time, orthopedician told no need to do any further surgery. In a particular one case I'm talking about. After that, I'm practicing prolotherapy in also tendo Achilles ligament injury, mainly
what
in
kind
the
of
sports
dextrose
injuries.
you are using?
25% dextrose. I am
Okay.
diluting with 0.5%.
And what are the
bupivacaine.
interval you are injecting?
It's 0, 3, 4, 7. If require, fifth dose. I mean first dose, then second dose after 3 weeks, then after 4 weeks of the second dose, then after 7 weeks, in this way.
Okay. Coming to next question to Dr. Stravani. How often you perform dry needling or wet needling?
Sir, if the patient is coming with a trigger point pain, then we can, under USG scan, we can see any specific knot if there is germline present, then we can go for dry needling. Otherwise, if there is just a tender point, like in myofascial pain syndrome, then we can do wet needling, local and steroid we can give.
Did you feel any difference in prognosis or in dry needling, between dry needling and wet needling?
Dry needling was, I think dry needling to be better.
Better. Okay. Any difference of opinion in house between dry needling and wet needling, and what kind of indication we are using for that? No, nothing.
Sir.
Next, you have.
Sir, for before the performing dry needling, we have to do the manual mobilization of the, if there is taut band, if there is levatoscapula involved at the insertion point of scapula, we have to do the manual exercise. There is specific, as the physical medicine, there is also specific exercise.
We will come into that. We will come into that.
That
Exercise
is,
part we will come into that.
that is called, no, that is the manipulation is called ischemic compression of the specific muscle.
We will come into that. Okay. So regarding dry needling, particularly in shoulder and in the back, what kind of precaution you have to take? Even nowadays we are doing dry needling under USG guidance, correct? But still you have to take a very important 2-3 precautions. Dr. Shamir.
First is the consent of the before the procedure, because we use the patch, the anesthetic patch before application of the prelocaine patch or something we use. So we have to take the proper consent, and this procedure, even after this, it is painful, and we have to take the consent for this. And
okay, consent. Any further opinion?
Aseptic precautions should be taken.
Yes,
and
aseptic
proper
precaution.
needle, the path of the needle should be seen, the tip of the needle before injecting anything, even if it is, we are doing wet needling.
Yes, and as well as the length, there are length of the needle is also you have to check, because there is intercostal areas.
As well for deeper
Pneumothorax
structure.
can happen. And yes, anticoagulation, use of anticoagulation is to be excluded. Okay, fine. Next. If you are doing dry needling, Dr. Sandipan, will you rely only on jump sign, or you just go on doing needling like that?
No, every sign has a phase so don't go for the jump sign is present or not. If it is band, and if there is band and if it is present and it is taut, trigger or tender, then you can go for that.
Okay, fine. Next question.
Actually, there is a different kind of.
Okay. Yes, yes. But during needling, you can also find. Sometimes jumps. Now, what is the frequency of this needling? Repeat needling. Dr. Piali, if you are using needling?
If dry needling, then you can be like repeat after 2 weeks, 3 weeks like that.
How many times you should do it? A dry needling or wet needling?
How many times? Till the pain reduce, and in between we can give some home therapy like physiotherapy, stretching exercise kind of thing, and then ask the patient and follow up, and accordingly we can do, if there is any more myofascial bands we can palpate, then accordingly we can do the another setting.
Till the sign and symptoms get relief. Okay, fine. Coming to next question. What is the scope of Botox in shoulder pain, Dr. Piali?
Yes, I use Botox. For shoulder pain, if there is a myofascial pain syndrome, I use trigger points we locate. Accordingly, we instill 5 to 10. In fact, if there is a jump sign is present, then we can go up to 10 units also, each site.
Understood. But it is costly also. I was doing dry needling at maybe 500 rupees. You are doing Botox at 4,000, 5,000. What is the sitting minimum
See,
charge?
50 units, you will get 50 units minimum.
Yeah.
That will cost you around
1200.
12,000.
So that's why I am telling. That's why I am telling you. So I am doing dry needling at 500 rupees, maybe 4 or 5 sitting for the same myofascial pain and for the same band, and you are doing Botox. Now, what is in your experience? What is the difference between
See,
Botox
only
and
one time Botox. Botox, actually, I look for spasticity. In my specialty, I treat spasticity with a Botox. Sometimes we call the patient accordingly. So 50 units is not needed for the myofascial pain. Like if one spasticity management, we sometimes for one limb, we may need 400 to 500 unit. So sometimes it's little bit of left, then we call the patient and I will give. But only one time if you use Botox, it will give up to 6 months relief. If you properly do and followed by therapy, physiotherapy.
And I can guarantee you with a single dry needle, it is not possible for 6 months. That is only different.
Single dry needling I have tried even on me. I am a chronic patient of myofascial pain syndrome. It doesn't get relief by dry needling.
No, not really. Those who are doing. Yes.
All these myofascial pain, rather than doing a dry needling or Botox or anesthetic or steroid.
So I have started already. I have injected that patient also.
The muscle layer that will be giving long lasting, single injection.
Yes, Kanchan was telling in that session, and I injected in last patient only. So, it is not a problem.
Hydrodissection of the
With the dextrose.
With the dextrose, the muscle layer. Like say for example the shoulder, you can inject it below the deltoid muscle or below the trapezius muscle, depending on how you are getting the care.
Sir, I have a question. That the patient is coming recurrently with the tender point, so we differentiate it from the acid joint pain.
Yes, obvious.
So in fact, what I was telling also that all the different kinds of shoulder pain has been discussed, but one I will take just 2 minutes. Means just because you were asking. So the shoulder pain first is very important. Extrinsic cause and intrinsic cause. So extrinsic cause means it is coming outside the shoulder joint, and extrinsic means it is coming referred from other areas. So extrinsic cause must be ruled out, and what PLE was telling, that is also very important. What investigation will be doing depending on our clinical findings. After we are ruling out the extrinsic causes, in the intrinsic cause you should be broadly glenohumeral and extraglenohumeral. Glenohumeral joint, to understand, is very simple, is whether active and passive both are restricted.
Both are restricted.
If it is, then it is your glenohumeral. If not, then it is extraglenohumeral. Extraglenohumeral, again, the commoner thing, your rotator cuff tendinopathies and the bursitis. These are the most common things. And apart from that, top of that, the myofascial pain around all the muscles what is getting involved. So if we are summarizing that, then only we can classify the treatment further. So coming back to the dry needling and trigger point, in fact, in my practice, Botox, dry needling, white needling, everything now I am coming back to the,
exactly.
the dextrose injection.
Okay, thank you, sir.
It is 5% dextrose, physiological solution, and volume you can give few liters also. Sorry, that is a joke. 5, 10, 20. Even if you are giving larger volume, basically it will be quickly getting absorbed. So like all other restrictions are there when you are giving local anesthetic, steroid and other things, but for the dextrose there is no restrictions. What is important, we should be always doing under the ultrasound guidance, you should see that the two muscle planes are nicely separated. When you are seeing that the two muscle planes are nicely separated, you go on giving that much volume. Yes, it is 5% dextrose. Dextrose load is not that much.
So next question to Dr. Sandipan. What kind of exercise do you prescribe to these patients? This one.
First thing is a posture correction. If there is any postural abnormality, if there is any dyskinesia in the scapula, and then strengthening exercise and range of motion exercise.
Can you slightly elaborate what kind of strengthening exercise so that some juniors are...
range of motion, there is 3 kind of exercise. One is range of motion exercise, that is the simple that do the range of motion of the joints, and next is the strengthening. Strengthen the specific muscle if you want, if you just look for that. Then is stretching. If there is, actually stretching is very important for the tender point. If there is any tender point, stretch that muscle.
Okay. Next question. So, what kind of application of heat or cold, Dr. Piali, and what may be the mechanism?
See, heat and cold both has a some of the effect.
Yes, but
like
we are confused.
Yes, heat causes direct vasodilatation. Okay, and what cold does? Cold does reverse vasodilatation. It also causes the vasodilatation. First, it will cause, cold will cause first vasoconstriction, followed by reverse vasodilatation. So what do you think, which will be better working? Cold, sometimes for the acute, sometimes for the chronic also, I suggest the patient to heat and cold, both you can use accordingly.
Alternative?
Alternative, like 5 cycles of heat and cold. By heat, cold, and if there is a swelling, finish with the cold. If it is not, then can be finished with the heat also.
Okay.
If there is an acute phase, then we should not use heat at all. Then that time we will cause the cold, we'll ask for the cold, and that time, of course, we can think of reverse vasodilatation, but sure. First you have to remember that there will be a vasoconstriction.
Sure.
Yes. Yes. Yes, sir. There is a numbness of the nerve fibers. Yes, yes. Firing of the nerves also can cause. But for chronic case, sir, cold will not. I have in clinical practice, I have seen many patients. Cold, if we only singly give cold for the chronic pain, it will not get relief.
Actually, there is no such consensus. Depending on the patient's comfort.
But I have got very good result with the heat and cold alternative. The contrast using, I have get lot of good result.
Next question to Dr. Sandipan again. IFT, UST. Confusion? What to use? How to use?
UST has little bit greater penetration. It is about 88 millimeter, and IFT is about 4 millimeter. But basic difference is that IFT you can use for a larger area, and UST is a smaller area.
Can you please explain slightly more? I do not know anything IFT and UST.
Because the thing is that in UST the probe size is this much, okay, and you have to just rotate the area around that. Okay. If you are targeting a larger area, go for the IFT.
What is the indication for this case?
Both of the indication is the chronic bursitis, chronic pain is the same.
Pain of what origin? What kind?
Bursitis, tendinitis, muscle pain.
Okay. At what should be the duration will continue? Up to still the pain is get relieved?
It is depending on that. If it is not relieved by at least 2 weeks, then stop and go for other intervention. If it is relieved by 2 weeks, then you can continue.
Okay. And what about IFT?
Same thing.
Same. Both are same. Okay.
The only difference is the depth of the penetration.
Depth of penetration.
But as a physiatrist, I also add on this, IFT or UST, whatever you use. UST has some result in acute bursitis kind of thing. It gives, most of them, it gives a placebo effect.
Okay. Next question to Dr. Sravani. What may be the use of TENS in shoulder pain?
TENS, in case of chronic pain, we are basically using. Actually, this is Dr. Sandipan can tell better.
Actually, TENS is previously used for that neuropathic pain, but in some papers they have used for that chronic pain also in shoulder. But the thing is that what Dr. Piali has said, that 50% analgesia is by placebo analgesia. So if you have the modalities and patients is telling that I am benefiting from that, you can continue.
Can we use
for
it in
TENS,
entrapment?
Yeah. I can add, for TENS, it doesn't happen. TENS, actually it causes, it stimulates the afferent fibers, and followed by, if you, for 15-20 days, if you can use TENS for 15-20 days, at a stage. First, it will increase the pain, and later on, it will decrease the pain. It will not always have 15-20% can be the 10-15% can be the placebo, but for the long-term use stains, it will stimulate the inhibitory fibers, which can decrease the pain. It is actually gate control theory.
So coming to, madam, you want to add? So coming to psychological interventions, because as in newer definition of pain by ISP, psychological things is equally important as the physical thing, correct? So the next question to Dr. Samir, what are the management options for phantom limb pain? Because just now we have seen one phantom limb pain and patient categorically said that I did not continue dose therapy, that's why it has been recurred and this is continuing even after almost 2 years. So what are the options do we have?
So for this condition, there is the non-interventional treatment like the occupational therapy or the physical therapy. These are options. There is the mirror therapy. There are so many treatment modality that is non-invasively we can use for phantom limb pain. That is so that we, by seeing a normal limb in mirror therapy, this type of pain may be controlled.
Okay. Okay, so here Dr. Anirban Pal is here. He is using mindfulness for quite a bit of time. Do you have any role of mindfulness in phantom limb pain?
Yes, there is a role of mindfulness, and we actually planned a study where we will be giving mindfulness to phantom limb patients. So there are a little bit of evidence of mindfulness helping them to accept the pain and to look at the pain from other different perspective. In that way, there is a definite role.
Thank you. Next question. Do you have anyone here practicing palliative medicines? Anyone? No? Any? Okay. So the question is, patient under palliative care treatment sometimes present with severe pain due to skeletal metastasis. Okay. Dr. Manish? So in this situation, how do you manage?
Yeah, so in a palliative setting, so it is approached from a total pain perspective, from physical, psychological, social and spiritual. And for the physical part, in case of bone pain, so there are very different modalities available. Initially, we start with a tramadol, depending on the WHO pain score, WHO pain scale. And for mild pain, we start with paracetamol and NSAIDs and adjuvants. And then for according to the scale, we give weak or strong opioids. And for bone pain, what are the modalities available? One is the zoledronic acid, which can be used in particular patients who don't have any diminished kidney functions. And also, there are different modalities available for skeletal mets other than zoledronic acid. It can be due to osteoporosis also. We have to rule out that if possible by bone scan, and there is a role for denosumab. So that is a big spectrum. So according to the patients, we can decide which therapy to give in. But again, we have to stick to the WHO pain scale and the total pain perspective.
Okay. So next question is, obviously these patients are coming with anxiety and depression, and both are very common in these kinds of patients. So any psychologist patients here? Anybody? So, or psychiatry medicine? It's not there. Oh. Okay. So Dr. Oniban, yeah, if you can add something in this background.
One thing I would like to just emphasize out here, I've been hearing the discussion from the very start of the thing. It is not actually the pain. There are other things which are bothering our patients. It is not only the pain. We are always talking about pain. But suppose the patients who came, some of them may have been losing their job, or there are issues with their professional life. Suppose you have a shoulder pain and it is very severe, and just look at me. I was having a shoulder pain just 1 year back, and I even went to Gautam Das sir for it. So I am an anesthesiologist, I have left shoulder pain, so I cannot do the laryngoscopy and intubation. So it's a major issue for me because my profession was at a stake or at a problematic situation. I didn't know that how will the pain behave and what will happen. So these are issues which are very important. You can have problems with your relationship with this pain. You have severe shoulder pain, there will be lot of problems in the family. And there are other problems. You don't want to socialize, you don't want to go out. So these things has to be taken care of. It is not only about anxiety and depression. Anxiety and depression are other things, but these things are the emotional part of pain, the psychosocial part of the pain.
And
which
then
needs
what
to
do
be
you suggest to them?
So they need to, we as pain physicians, we can just start with it, then they can go for mindfulness, or they can go for psychotherapies like CBTs and this, because these are very important things which
Correct.
are not discussed usually. But
Yes.
these are the actual practical things which are bothering the patients. It is not only the pain.
Correct, correct. Okay, thank you. Yes. Yes, that we are actually already using, because when we are treating for chronic pain, we are using duloxetine kinds of, or amitriptyline. We are already using those. So we are already using that. The question was above or on top on that. The next question to Doctor, this is the best to be Sandipan. So how to practice regular exercises to prevent shoulder pain, or what may be the behavioral changes we can perform in our life? And this is the last question.
First thing is the regular exercises. That thing is that now every societies are telling about that any chronic pain, go for the aerobic exercise, for large muscle exercise like walking, swimming.
No,
running.
I am talking for shoulder. We are
For any
restricting
pain, actually in any chronic pain, it is any chronic pain, there is central sensitization, and central sensitization reduces by aerobic exercises only. And if for chronic pain, for particular joint, you can go for the range of motion exercises and stretch.
Correct.
But you are right for all kinds of chronic pain.
Swimming, running, jogging, walking.
He is already saying aerobic exercise.
Aerobic
so
exercise
one line
is the
answer. So
move. Actually, I think some societies are also suggesting that 1,000 steps per day, 10,000 steps per day. 10,000 steps per day.
Goswami says one of the favorite that exercise cause endorphin, endogenous endorphin secretion, which will cause the pain relief. As I used to say all the time.
So that's all for today. I would like to thank all the faculty members and all here. So you just stay there.
I'm sure everyone present here really enjoyed this session. To felicitate the doctors, I'd like to invite Dr. Dipanjali Roy. Please, ma'am. Dr. Sanjay Patwari, please come on the stage. Dr. Shomir Boshak. Dr. Piali Boshak. Dr. Shravani Shorkar. Dr. Sandeepan Hazra. To conclude the event, I'd like to call upon stage Dr. Gaurav Maitra, our senior consultant anesthesiologist and pain physician at Apollo Multispeciality Hospital. He is currently the vice president of WBSSP. Sir, please.
Good evening, everybody. This was indeed a very well organized CME, and it covered almost everything from case presentations to the history taking and the examination of the shoulder joint, and also the relevant causes of shoulder pain, the relevant anatomy, the demonstration of the sonoanatomy, and the vivid discussion on the various pain management options of shoulder pain. So for this, I think it has been very beneficial for the young pain physicians, and I think this type of CMEs should go on and continue. And I would like to sincerely thank all the speakers and the chairpersons who have contributed to this CME, and also the organizing committee, particularly Dr. Debanjali and Dr. Orgho. It's a fabulous work, such dimension in a very short time, and has helped us, everybody, the young and the older generation as well. And lastly, I also want to thank our event sponsor for sponsoring that, this Modi Mundi Pharma. And lastly, I want to, my pranam to Dr. Subhrata Goswami, Akash Subhrata Das, as I knew him since my Calcutta Medical College days. And it's an honor to be speaking on him, because I've seen him grow over all these years. And on this day, with the condolence meeting and the CME, academic activity, if we can go on doing this kind of pain management CMEs, it will be part of carrying his legacy. So with that, I conclude this meeting, and thanks everyone for attending this CME.
Just one thing that I want to add. Please, I'd like to invite Dr. Jayanto to felicitate Dr. Gaurav Mitra. Just final words from my side. I'd like to thank Dr. Orgo for giving me this opportunity to host such prestigious dignitaries, and I'm really sorry for any glitches.